Hi friends, I hope all of you are doing as good as ever. Welcome to this edition of the quick revision slash the rapid revision notes, which have been made in the upgraded format just for the benefit of all of you who are going to be watching these videos from the perspective of all the subsequent exams that you are appearing in, be it the NEET PG exam or the INI-CET or for that matter, the FMG exam. Before we start off with the rapid revision discussion, just a gentle reminder about the capabilities that you have in yourself. When Sir Edmund Hillary made a mention of this particular statement, it's not the mountain, but it's us. That means you are conquering your own self-doubts when you are going to be conquering any kind of a seemingly unachievable task. So usually any task which is going to be appearing something which is very, very difficult, be it a mountain, be it appearing in the exams and getting a very good score or very good rank. But the primary reason why people are able to achieve this is that they overcome their mental inhibitions, they overcome their mental barrier. So going ahead with an optimism and a wonderful positive thought that all of us can achieve whatever we wish to in our life, we are going to be starting on the discussion for this particular video. Now, starting off with the discussion of the topic in context of general pathology, we are going to be talking about cell injury. And as and when we are making a mention of cell injury, we need to just quickly revise about the important features associated with adaptation. So we understand the fact that when we are going to be talking about something like hypertrophy, there is going to be an increase in the size of the cell because of the functional demand. And the way the questions are going to be asked in the exam would be clinical questions where they can talk about either the examples of physiological hypertrophy or they can give you examples of pathological hypertrophy, amongst which the classical example is of a cardiac hypertrophy or a big size heart in a patient who has been suffering from hypertension. The second important adaptation that you have to keep in mind is hyperplasia, which is associated with an increase in number of cells, can be both physiological or it can be pathological, again with the relevant examples that have been given over here and that can be given to you in the exam. A third one that you need to keep an eye on is atrophy, which is going to be decrease in size and function of the cell, which can be because of physiological atrophy, as can be seen because of a decrease in the blood supply associated with something like aging, or that can be because of something like a classical example, thymic hypertrophy, or we can be having a situation wherein we are talking about pathological atrophy associated with disused atrophy in context of a skeletal muscle. The most frequently asked adaptation in the exam, however, happens to be something which is given the name of metaplasia, wherein one type of a cell is going to be replaced by another important type of a cell. It can be an example of an epithelial metaplasia or it can be an example of a connective tissue metaplasia. The commonest question asked in the exam is also an image-based question, wherein they ask you about a history of a patient who happens to be a smoker for a long-standing time, and this individual is going to be having the presence of a squamous metaplasia. That's a commonest example of an epithelial metaplasia. Please bear that in mind. If they are giving you an example from the GI tract, we have a classical example of something like the patients of gastroesophageal reflux disease who are going to be having the presence of intestinal columnar metaplasia, and therefore they would be having two important types of epithelial linings. So that is what is being given the name of Barrett's esophagus. Whenever we are talking about the classical example of connective tissue metaplasia, the classical example of a connective tissue metaplasia is going to be a condition that is given the name of myositis ossificans. Now, the way the questions had been asked in the exam, if you remember, 2018-2019, they give you an example of an image-based question which was taken directly from the Robbins. That was a 2019 NEET PG question wherein they gave you history of a patient having a smoking and the presence of a squamous metaplasia. Classical example of a question from FMG 2016, 18 and the NEET PG 2020 wherein they gave you an example of an intestinal columnar metaplasia as is seen in patients suffering from Barrett's esophagus. How do you make a confirmation for Barrett's esophagus? Because of the presence of goblet cells which are a characteristic of intestinal columnar metaplasia. And how do you confirm goblet cells? Is because of the presence of the staining caused by Alcian blue. The Alcian blue is responsible for staining acidic mucin, and this acidic mucin, please remember, is what is going to be typically seen inside the goblet cell. So that is how you are able to pick up the goblet cells and you are able to make a diagnosis of the intestinal columnar metaplasia. One important question that we got in the exam 2022, if you remember the INI-CET, wherein they gave you a description of a patient who was having the presence of dysplasia, where they made a mention of a patient having a history of suffering from an infection caused by the human papilloma virus, and there was presence of cells which are having the presence of hyperchromatic nuclei. They were disorganized in nature, but they were not able to penetrate deep inside the tissues because they were not able to cross the basement membrane, right? So that was an example of a question which was classically describing the features of dysplasia. It did not make any mention of abnormal mitotic figures. If you have features of hyperchromatic nuclei containing cells which are going to be having an irregular shape and size, there is a loss of polarity and you're having the presence of abnormal mitosis, that's very much suggestive of anaplasia. But once you are having no mention of a word irreversible, no mention of the word abnormal mitotic figures, then you have to think in terms of disorganized hyperchromatic cells, especially in association with the human papilloma virus with a shorter durational history associated with something like cervical dysplasia, right? With regards to dysplasia, in the early stages, it happens to be a reversible change. But if it is untreated, then over a period of time, it is going to become irreversible. And of course, then it can progress to something like anaplasia, right? So those are the important types of adaptations that we need to keep an eye on. Then having a quick revision with regards to something which is given the name of reversible cell injury. So of course, we understand the fact that the commonest reason happens to be a depletion of ATP concentration inside the cell. And that is going to be having a consequence that the size of the cell is going to increase, right? Because of entry of more water. So that's what is going to be given the name of hydropic change as the earliest morphological manifestation. We could be having the presence of blebbing of the plasma membranes. We could be having the presence of intracellular aggregation of phospholipids in a fashion which is going to be given the name of myelin figures. So myelin figures are going to be just like those spirals that we have talked about in the main video section as well. There is going to be a decrease in the protein synthesis because of ribosomal detachment, and the chromatin is going to get clumped. However, if the process is going to continue over a longer duration of time, that means depletion of blood supply for a longer duration of time, this is going to be responsible for causing one particular pattern of cell death, which is given the name of necrosis. Now, the moment we think in terms of necrosis, that's a wonderful table, which is going to cover almost everything that they are likely to be asking in your exam. So necrosis, the commonest example that we have to keep in mind is that of coagulative necrosis. This is going to be associated as a commonest histological pattern of necrosis that is observed. It is associated with preservation of the tissue architecture. So remember that one-liner word tombstone appearance, that was a NEET PG 2016 question. There can be an example of a presence of a triangular area, which is given the name of an infarct. And therefore, anywhere where you're going to be having the mention of a term infarct, myocardial infarction, renal infarction, that is going to be associated with coagulative necrosis. We must not forget a special example. In patients suffering from enteric fever or typhoid, there is involvement of the abdominal muscles, skeletal muscles, particularly the rectus abdominis, which is going to be associated with the keyword over here, which is going to be given the name of Zenker's degeneration. So even though the word is degeneration over here, remember, it's not a degeneration actually, it's an example of coagulative necrosis, right? The other thing that we need to remember over here is the second pattern of necrosis, that is liquefactive necrosis. So there is a liquefaction of the affected tissue. The alternative name given over here is colliquative necrosis. That's an MCQ term that you have to remember. We are going to be having the presence of a classical example of CNS involvement, that's given the name of brain abscess, or you could be having it in a patient suffering from involvement of the pancreas. Say for example, a patient suffering from pancreatitis. Remember the FMG 2024 question? They gave you a history of a patient having a history of alcohol intake. There was an increase in the levels of amylase and lipase. And the question was asking you about the type of necrosis which is going to be seen in such a patient. So patient having a history of alcohol intake, lipase, amylase elevated, suggestive of pancreatitis, is going to be having the liquefactive necrosis of the pancreas gland. However, the catch in the question was that around the pancreas, you would be having the presence of fat necrosis. So in the pancreas, liquefactive necrosis, around the pancreas, that means peripancreatic tissue, you would be having the presence of fat necrosis, right? So that's a classical example of an image that you must always remember for your exam purpose, that you are going to be having the presence of a triangular area, that's an infarct. And this is going to be a picture of the brain, which is going to be showing you the liquefactive necrosis, right? Talking about the third important example, which had been asked in almost every exam after 2020, if you remember, caseous necrosis, which is going to be associated with the cheese-like appearance of the necrotic material and quite commonly associated with infection like tuberculosis. Now, how is it different from the other patterns of necrosis? Is because in this pattern, you are not having neutrophilic infiltration. You're rather having the presence of granulomatous inflammation. Granulomatous inflammation. Now, with regards to the questions asked in the exam, they can ask you the question as they did in 2021. A child who was having the presence of fever, cough, he was having the presence of cervical lymphadenopathy, and he was having the presence of a granulomatous lesion. So that's likely to be associated with tuberculous infection. Another question asked in the exam is they'll give you a picture of a patient who is having a granuloma formation, which I'm going to be showing you subsequently. And they ask you what is the reason for the presence of this kind of a tubercular granuloma formation. So one of the reasons is that you're going to be having the secretion of cytokines, especially interleukin 2, interleukin 12, and interferon gamma. Same reason, interferon gamma, which is responsible for causing, remember, macrophage activation. That's the reason why there is a collection of macrophages in case of a caseating granuloma. Now, apart from tuberculosis, do we have any other examples of conditions where we have caseous necrosis? The answer is yes. And that can be seen in case of fungal infections, especially in case of systemic fungal infections like histoplasmosis. Remember histoplasmosis from your microbiology, Darling's disease, which is going to be associated with a person who's having a history of some kind of an adventure or trek lover. He goes to a cave, he finds that there is presence of bat or bird droppings over there. This individual is now going to be having an infection caused because of histoplasma capsulatum, right? So that is what is going to be again associated with the presence of a caseous necrosis. The next example that we talk about over here happens to be fat necrosis. Fat necrosis is something which is going to be characterized by the fact the patients are going to be having destruction of the adipose tissue by activation of an enzyme like lipase. And because there is going to be a deposition of calcium, so it is going to be associated with a keyword over here, saponification. Remember, because of the saponification, there is going to be a presence or deposition of chalk-like deposits. So yellowish white chalk-like deposits. Remember the word? When we are talking about cheese-like appearance, that is caseous necrosis. When we say chalk-like deposits, that is associated with fat necrosis. Classical example can be conditions like peripancreatic tissue in case of an individual who is going to be having acute pancreatitis, or that can be seen in case of an injury to the breast tissue, or that can be seen quite commonly fat necrosis in case of injury to the omentum. Just have a look at this kind of a picture, which is going to be suggestive of a patient who's going to be having a cheese-like appearance of the necrotic material. So this can be seen most commonly in case of tuberculosis, but can be seen in patients suffering from infection like histoplasma as well. If I'm going to be talking about this example of an image, that would be reminding you of the presence of the yellowish white deposits suggestive or associated with the chalk-like deposits. That is what you associate with saponification, and therefore this is something that you would be associating in a patient who is going to be suffering from fat necrosis. Another important example of necrosis that we have to keep in mind is going to be fibrinoid necrosis. The moment we are thinking in terms of something like fibrinoid necrosis, we are thinking of a breach of a vessel, because of which immune complexes and the plasma proteins are going to leak into the vessel wall. And that's the reason why you would associate it in a patient suffering from malignant hypertension. You associate with immune complex disease and with certain examples of vasculitic disorder. Amongst the vasculitic disorders, you must remember over here, polyarteritis nodosa, as well as a condition that has been asked in the exam couple of times in 2023-24, Hinox-Schönlein purpura, which is nowadays going to be given the name of IgA vasculitic disorder. How is going to be the appearance for the fibrinoid necrosis? So you are having the presence of a vessel over here. This is going to be having the presence of cells over here, and you are going to be having the presence of the plasma proteins which are going to be present in the vessel wall. So that is what is going to be associated with fibrinoid necrosis. The next example that we talk about is gangrenous necrosis. In gangrenous necrosis, you are going to be having an ischemic damage, and subsequently there may be a presence of a secondary infection as well. If there is only going to be a decrease in the blood supply, ischemic damage only, then that is given the name of a dry gangrene associated with coagulative necrosis. And if you are going to be having a secondary superimposed infection, then that would be associated with wet gangrene term, and that is quite commonly associated with liquefactive necrosis. So that classical example of a ward picture where you get an untreated patient, an untreated diabetic patient who is having the presence of the classical diabetic foot, can be showing you the presence of maybe a pretty black colored appearance of the dry necrotic tissue, or there can be an example of, as you can see over here, the pus material over here, suggestive of very much the presence of a liquefactive necrosis, which is associated with the term wet gangrene. One example of wet gangrene that is specifically asked in the exam is a one-liner, especially the FMG exam, is the one which is going to be affecting the perineal area, which is going to be given the name of Fournier's gangrene. So it's an example of a mixed infection, and that's going to be associated with the involvement of the genital area. That is what you need to keep in mind. Why we talk about Fournier's gangrene is also going to be a pharmacology related question, that this could be associated as a complication of a anti-diabetic drug as well, especially the ones which are going to increase the amount of glucose in the urine of a patient. That means the drugs that we are talking about, the dapagliflozin and the canagliflozin, which are example of SGLT2 inhibitors, right? So they can be causing complications like Fournier's gangrene in a patient. And of course, that is more likely to be seen in a female patient in comparison to a male patient, right? So that's what you need to remember over here. Now, with regards to necrosis, another important question which was asked in 2023, INICET, necrosis is never ever seen physiologically. Please remember, it's always an example of a pathological change. So you get the presence of a plasma membrane disruption over here. There is going to be an enzymatic degradation of the cell over here. There would be presence of certain types of nuclear changes, pycnosis. You're going to be having the presence of karyorexis. You would be having karyolysis. But please remember that necrosis is never ever going to be physiological. It's always an example of a pathological change, right? Having said that, the next important thing that we need to remember over here is, just for the sake of a revision of what was told to us way back in the medical schools, the differentiation between a red infarct and a white infarct. can be asked in the exam, relatively more commonly in the FMG exam, and also a NEET PG question, less commonly asked in the INI exam. So red infarct is the one in which you're going to be having the presence of loose connective tissue, right? And typically they are going to be seen in organs which are having a dual blood supply. So classical examples of that would be liver as well as that of the pulmonary tissue, right? So hepatic tissue, pulmonary tissue would be showing the presence of a red infarct more commonly. It's far more commonly associated with a venous occlusion in comparison to arterial occlusion. Or another example can be in a situation where the individual is going to be having the presence of a reperfusion injury, right? In context of white infarct, it's going to be seen in organs which are classically going to be having the presence of an end arterial blood supply. So any kind of a solid organ which comes to your mind, the one which you are associating with something like, let us say, a myocardial infarction, or a patient who's going to be having a renal infarct, which is going to be seen because of obstruction present in the arterial circulation. So arterial circulation, especially end arterial circulation, and there is involvement of a solid organ over here because of the presence of a single blood supply. S for solid, S for single. That's the area where we're going to become having a white or a safed infarct. Remember, S, solid organ, single blood supply. It is going to be appearing pale or it is going to become safed. So that's going to be a white infarct. And usually, of course, there is no presence of any kind of a reperfusion over here, right? The second important example of cell death that they have asked in the exam quite frequently is the programmed cell death that is dependent upon caspase, which is given the name of apoptosis. Now, this can be an example of both physiological apoptosis or can be an example of pathological apoptosis. Classical example of physiological apoptosis that you need to remember over here is embryogenesis, or we can be talking about the involution of certain tissues, like for example, the breast tissue, for example, the endometrial tissue, when there is a withdrawal of the hormonal support. For that matter, even in case of the concept of tolerance that we see in immunity, whenever we are having the presence of, unfortunately, self-reactive T cells or self-reactive B cells, then they are being destroyed by the process of apoptosis, right? So those are examples of physiological apoptosis. The moment we are thinking in terms of pathological apoptosis, we can be thinking in terms of something like viral hepatitis, would be reminding you of something like the presence of a council body, or we could be having it because of presence of accumulation of misfolded proteins. Remember, misfolded proteins, there can be a lot of reasons. Say, for example, Alzheimer's, Parkinsonism disease. What you got as a question in 2021 exams, the Creutzfeldt-Jakob disease, or they can also be seen at times because of conditions like atrophy of the duct. Say, for example, the pancreatic duct obstruction can also be responsible for causing pathological apoptosis. Now, what is going to be the mechanism involved over here? So, importantly, that we need to remember over here, there is going to be a caspase-dependent programmed cell death that's going to be affected by genes. And why are we talking about caspases? This was a previous INA question. So, caspases refers to cysteine-containing proteases, which are going to break the target site wherever you are having the presence of aspartic acid. It classically is going to be affecting small group of cells. And what you are finding over here is, in case of apoptosis, the size of a cell is going to decrease. Now, that was the basis of a question asked in INI CET, if you remember 2023, wherein they asked you the differentiation between necrosis and apoptosis. So, enzymatic destruction of cell is classically associated with necrosis. When we are talking about damage to the organelles, that is again classically seen in case of necrosis. When we are talking about the differentiation in the cell size, in necrosis, the cell size is going to increase. In apoptosis, the cell size is going to decrease. Alright. So that's an important thing. Inflammation can be one differentiating factor. Inflammation is present in case of necrosis. It is absent in case of apoptosis. What is exactly going to be the hallmark feature for apoptosis? That is going to be something like chromatin condensation. Now, because you are having the activation of caspases, so nucleic acids are going to break down and they would be giving you a classical pattern, which is going to be given the name of a step ladder pattern. So, step ladder pattern is what you are going to be having over here on the gel electrophoresis. Remember, in distinguishing this from necrosis, necrosis on gel electrophoresis would be having the presence of a smear pattern. So, that's important for you to keep in mind. Now, one of the important features of apoptotic cells is that they are quickly removed from the site of injury because of rapid phagocytosis. And this rapid phagocytosis, please remember, is what is given the name of efferocytosis. Remember, this is what we discussed. This is also an example of a cell within cell phenomena. So, there are 4 examples of cell within cell phenomena: emperipolysis, entosis, efferocytosis, and enclysis. So, the type of cell within cell phenomena which is associated with apoptosis, that is what I want you to remember, is given the name of efferocytosis. What's the reason for the presence of efferocytosis? The reason for the presence of efferocytosis is because of the presence of molecules like phosphatidylserine. Another molecule contributing over here is C1q. Another molecule contributing to this efferocytosis is thrombospondin. So because of expression of these molecules by the flip mechanism that we discussed, we are going to be having rapid phagocytosis over here. What can be the stains or the markers for detection of apoptosis? We are going to be having a marker in the form of annexin B, and we are going to be having another important marker in the form of DAPI. So DAPI and annexin B are the markers that we are having for apoptosis. What exactly is going to be the gene contributing to the presence of apoptosis? So this was an example of a very classical INI-CT as well as the multiple choice question which was asked in the NEET PG exam as well. The pro-apoptotic genes would include the BAC, P53 and glucocorticoids. P53 being the most important one, present on chromosome 17. The glucocorticoids very important because that's what is going to be useful for their anti-cancer effect as well. Anti-apoptotic genes were asked in the exam more frequently. If you remember 2022, 2023 INI-CT questions, we've got asked question in the exam. Most important anti-apoptotic gene is BCL2, right? This is also contributing in the pathogenesis of a patient suffering from follicular lymphoma. We are also asked a question in the exam with regards to genes like BCL-XL gene. So that was an INI-CT question. And the 2023's question, MCL1 gene, which has been contributing in the development of something like the chemo resistance. So that was the latest exam question. Apart from that, sex steroids 2018 question INI-CT was contributing to the presence of having an anti-apoptotic action. Certain types of molecules or genes are going to be given the name of sensors or also called as apoptosis initiators. That would include the BIM, BAD, UMA, NOXA, not for FMG exam usually, only and only for the NEET PG and INI-CT. This is what we can remember from our main video discussion, that you are going to be having increased permeability of the mitochondria, responsible for causing a leakage of cytochrome C, which is going to be responsible for causing activation of EPAF. This EPAF was responsible for the formation of a hexamer, which is given the name of apoptosome. Apoptosome is responsible for activation of, remember the NEET PG question, pro-caspase 9. That is responsible for getting converted into caspase 9. Then we had executioner caspases 3, 6, 7, activation of protease, activation of endonuclease, and finally cell death. With respect to the extrinsic pathway, we had the attachment of molecules like TNF and the fast ligand with the receptors, the TNF receptor and the fast receptor. It was responsible for causing activation of the FAD, that is a fast associated death domain, responsible for causing activation of caspase 8 and caspase 10, and then again it is responsible for causing the activation of executional caspases 3, 6, 7, subsequently causing cell death. Now what we also need to remember over here is that whenever we are going to be talking about certain important examples, we need to be having an idea of CD8 T cells, very important, because they are going to be responsible for causing secretion of certain enzymes like perforin and granzymes. And why are they important? Because they are going to destroy the target cell by activation of apoptosis. So CD8 T cells, which you recall from a discussion of immunity earlier, is what is going to be contributing to the development of type 4 hypersensitivity reactions, are going to activate apoptosis by the process or by the release of enzymes like perforins and granzymes. FLIP is an example of a protein which is going to be responsible for causing inhibition of activation of caspase 8. That was an example of a previous NEET PG question. So far as the role is concerned with respect to the clinical disorders, overexpression of BCL2, as I discussed with you, is seen as a feature of B-cell lymphoma. So BCL, B-cell lymphoma, especially which one? We talked about the follicular lymphoma. P53 underactivity is going to be responsible for causing multiple cancers in different members in the same family tree. That's what is going to be associated with the term Li-Fraumeni syndrome. Any kind of a defect in the interaction between the fast ligand is responsible for causing autoimmune lymphoproliferative syndrome, where the patients are going to be having the presence of organomegaly affecting the spleen, liver, and are having cytopenias. And that's what is going to be given the name of ALP, autoimmune lymphoproliferative syndrome. For purpose of image-based questions, this is what I would like you to remember. This is the smear pattern that you are going to be seeing with necrosis. On your left side, appearing as A is an example of a stepladder pattern that you would associate with apoptosis. Similar question which has been asked in the exam is with regards to viral hepatitis patients who are going to be having the presence of a apoptotic body that is being given the name of Councilman body. Right? When you talk about apoptotic bodies, they would be having some fraction of cytoplasm. They are going to be having the presence of some kind of an organelle as well. Right? So that is what you need to remember, and some part of membrane as well. That was asked to you as an FMG 2023's question. Right? So Councilman body, viral hepatitis is what I want you to remember as of now. Right? Differentiation between necrosis and apoptosis is what I already explained you earlier, which was asked to you as a 2023 INI-CT question. Now, apart from necrosis and apoptosis, certain special patterns of cell death which are to be kept in mind. Enoichus, which was a previous NEET PG question, is seen because of the separation of the cells from each other. So cells are pretty emotional that way, just like humans. But they are going to die in the absence of their wonderful friend in the neighborhood. So loss of adhesion is going to be responsible for causing cell death. That's what is being given the name of anoicus. So far as necroptosis is concerned, necroptosis is also being given the name of programmed necrosis. Remember the word, it is caspase independent programmed cell death. It's an example of a condition in which there is a damage to the plasma membrane, and because there is a damage to the plasma membrane, inflammation is also going to be present. So that's very, very important. Another special pattern that we need to keep in mind is pyroptosis. Pyro word is responsible for pyrexia, therefore associated or related with infections. There is activation of a multimolecular complex that's given the name of inflammasome. There would be release of certain types of cytokines, more importantly interleukin 1. And you can be having an activation of caspase 1, 4, 5 and 11. And because there is going to be inflammation, of course, we are going to be having the presence of infection. So inflammation is going to be present over here. Autophagy, if you remember, was asked to you as an exam question. This was derived from the INICET 2023. Autophagy means self-eating of the cell. That means cell cannibalism. It is going to be associated with phosphatidyl ethanolamine lipidated LC3, which is light chain 3 as a marker. So that's important thing. In case of autophagy, you are going to be having the presence of a double structured intracellular organelle, which is going to be responsible for the fusion then with the lysosome, and that's how the cell is going to be having a destruction of the organelles which are having a deficient functioning or a reduced functioning. So intracellular, double layered, the phagophore and the lysosomic fusion is what is going to see in place, and this is important in clinically which kind of diseases: tuberculosis, inflammatory bowel disease, and certain types of cancer. So that was what was asked to you as a 2023's question, INICET. Talking then about ferroptosis, which was again a question asked in the exam 2022 INICET, in which you are going to be having the presence of an iron dependent cell death. And why is that important? Because iron is responsible for the formation of free radicals. Now, more commonly, this is responsible for causing a damage at the level of the mitochondria, especially the outer mitochondrial membrane, and there is going to be a damage at the level of the mitochondrial cristae. So, iron-mediated free radical injury causing a damage to mitochondria. These are the three important words that you need to remember with regards to ferroptosis. Now, if it is dependent on iron, it's easy for you to understand. The moment you are going to be decreasing iron, this is what is going to be responsible for causing decrease in the death of the cell by this mechanism. What is the status of inflammation over here? So inflammation is going to be present in this kind of a condition. So if you observe carefully, friends, I just want you to remember necrosis will be having inflammation. Necroptosis is having inflammation. There is going to be inflammation in pyroptosis. There is going to be inflammation in ferroptosis. And I repeat that apoptosis is not having inflammation. Please bear that in your mind for the perspective of a question asked in the exam. Now, as and when we are making a mention of something like the free radical injury, of course, we are aware it's an example of an autocatalytic reaction, which is responsible for causing damage to primarily all the vital organelles of a cell, be it proteins, be it mitochondria, be it DNA. What are the responsible enzymes for the formation of free radicals? Yes, we are going to be having the role that is going to be played because of the action of something like superoxide, which is going to get converted into hydrogen peroxide, and then that is going to result in the formation of hydroxyl ions. Right? So, hydroxyl ions is what is going to be the example of most powerful free radical. So, as we discussed earlier, this is what I need to remember from exams. So, hydroxyl ion is going to be an example of a very, very powerful free radical. We are asked questions in the exam on something which is given the name of Fenton's reaction. So, iron being an example of a transition metal, Fe2 plus gets converted into Fe3 plus. That's responsible for more formation of the hydroxyl ions, and that's why there is going to be presence of free radical injury. Why is this free radical injury important? Because this has been attributed as one of the commonest mechanisms for aging of an individual. And one of the indicators for the presence of a free radical injury is the deposition of the iron, the lipid derived pigment that's given the name of lipofuscin, right? Now, what can be the examples of the antioxidant enzymes or vitamins is the question that we are asked in the exam. So that's a biochem pathlink question. Remember the fact that you are going to be having the presence of certain types of enzymes like SOD. You are having enzymes like catalase. You are having an enzyme that is given the name of glutathione peroxidase, which are going to be responsible for decreasing the concentration of the free radicals. So they are examples of antioxidant enzymes. If you are asked question in the exam regarding the antioxidant vitamins, of course, you have to ace the exam. That's how you remember it, friends. Ace the exam with flying colors. So vitamin A, vitamin C, vitamin E are going to be examples of powerful antioxidants. Which of them happens to be the strongest antioxidant? Of course, the one that you and we are consuming every day in the lemons and in the citrus fruits. So that means vitamin C. Of course, we are having certain plasma proteins which are going to be having a protective role with respect to the free radical injury, and that are the example of proteins primarily which are going to be contributing or having an attachment with either iron or copper. For example, transferrin and ceruloplasmin. Now, free radical injury examples are very commonly asked in the exam in clinical history based questions. So, classical example can be reperfusion injury. Patient who has been given streptokinase, especially who has suffered from a thrombotic injury as in case of myocardial infarction. If there is a worsening of his condition, that's caused because of the presence of a reperfusion injury. Another can be radiation injury. So people who are going to be having exposure to, let us say, ionizing radiation, those radiations are going to convert the water inside the cell into free radicals that causes damage. Oxidative stress that has been attributed in the pathogenesis of so many disorders these days, right? Then especially when we are having an I would say concentration of certain types of transition metals. For example, Wilson's, too much of copper. For example, hemochromatosis, too much of iron. So more amount of transition metals means more formation of free radicals. So that is what is going to contributing to the free radical injury. And then certain classical example, for example, drugs like paracetamol, they cause hepatic injury because of free radical damage. Similarly, when you're talking about carbon tetrachloride, which is an example of a chemical that is being used in dry cleaning industry, even that is hepatotoxic, primarily because of the presence of a free radical injury. How do you decide that a cell is suffering from more free radical injury or more oxidative stress? That is because of a particular ratio. And this ratio is what is going to be given the name of the high the high oxidized glutathione is to the reduced glutathione ratio. So more is going to be this ratio. That means you are having more oxidized glutathione, and that is what is going to contribute to the presence of the oxidative stress status inside the cell. So that's what we just need to keep in mind over here. Now the next important aspect in the exams is going to be certain image-based questions which will test your information or knowledge, particularly with respect to the accumulation of certain types of pigments or materials inside the cell. The classical example of which would include something like lipofuscin. So lipofuscin, which is an example of a perinuclear golden brown pigment, and this is going to be an example of an intralysosomal pigment. It's an indicator for free radical injury. It is also called as wear and tear pigment, and that's accumulating very commonly in tissues like the cardiac tissue, in the hepatic tissue, right, as well as in the skeletal muscles at times. So this is going to be with respect to lipofuscin. Another one that we are asked in the exam is on something like the deposition of oil or lipids. So lipids which are going to be having special stains for their detection. So we are going to be using, for the purpose of sectioning, we are using liquid paraffin. We are using frozen section or cryostat so as to preserve them, especially in a real-time situation wherein we are going to be having the presence of an intraoperative patient and you wish to decide for the margins, see for the detection of lipids, and you're going to be using certain types of stains. For example, oil red O. So that is going to be staining the lipid as red. You are going to be having the lipids being stained as black with the help of Sudan black. That's what we need to remember over here, right? We do have the presence of an endogenous black colored pigment which has been derived from tyrosine, which is responsible for the color of skin and hair, which is going to be given the name of melanin, right? Remember the exogenous pigment on which they ask you a question in the exam, that is usually something like the anthracotic pigment or the coldness. Now, iron derived pigment, that's another important one that I want you to remember. Iron derived pigment is what is going to be given the name of hemosiderin. So that's how you're going to be having the appearance of hemosiderin in the form of the dark blue colored example of pigment, which is going to be responsible for being accumulated in case of iron overload conditions. Say for example, a patient who has suffered from multiple blood transfusions, and the kind of reaction that you're going to be observing over here is given the name of Pearl's reaction. So for the detection of hemosiderin, we are using a stain that is given the name of Prussian blue stain. And when this is going to be reacting with hemosiderin, the reaction is what is being given the name of Pearl's reaction, right? So that's what you need to remember. Of course, what we are talking about over here was about anthracosis. Remember the fact anthracosis is an exogenous black pigment, right? This is going to be seen in case of smokers. It is going to be seen in case of urban dwellers. So remember the NEET PG 2021 question where there was a guy who was having a history of smoking for a long duration of time. He was having the presence of enlargement of the hilar lymph nodes as well. His lung biopsy showed you the presence of black colored pigments being deposited, and they asked you to make a diagnosis. So that was a classical example of an anthracosis patient. Anthracosis, of course, is going to be having an association. When it is seen in combination with a patient who is going to be having rheumatoid arthritis, you get a name of a syndrome. And that smile on your face tells me you know the answer. So anthracosis and especially, Kohl-Werker's pneumoconiosis and the presence or coexistence of rheumatoid arthritis would bring to your mind the name which is going to be given the name of Kaplan syndrome. The moment we are going to be thinking in terms of something like glycogen, glycogen is going to be a pink staining material, and this is going to be accumulating mainly in the liver and the muscle, and is going to be particularly involved in case of disorders which are going to be given the name of the glycogen storage disorders, right? Where exactly are we talking about glycogen? Because glycogen is going to be staining positively with the PAS stain, and it's an example of a diastase sensitive material. Diastase sensitive material. So it's pass positive, diastase sensitive. Why is that important? You have other materials also which are going to be pass positive. Say for example, the fungal cell. The fungal cell membrane can also be staining positively with pass. But is it going to be diastase sensitive? No, it is diastase resistant. Similarly, we are asked question in the exam about certain types of infections caused by the bacteria. They may be pass positive. Amyloid, is it pass positive? Yes. But is it going to be diastase sensitive? The answer is no. So that's what is going to be important, that pass positive and diastase sensitive material happens to be only one that you have to keep in your mind for your NEET PG exam. That's glycogen. Whenever you're going to be talking about something like steatosis, that's just another way of asking you about lipids, about which we already had a discussion. That of course we can be using frozen section. Frozen section for that matter can be used for anything in which you are going to be having a real-time assessment, and then you want to just freeze the tissue so that the tissue architecture is going to be preserved, and the machine being used over there is cryostat. Another hot favorite for an examiner happens to be the extracellular material which is given the name of amyloid, and this is going to be made up of non-branching fibrils. It's going to be seen because of accumulation of misfolded proteins, and the importance of knowing about amyloid is it is going to stain positively with Congo red. However, the color that you are going to be obtaining with Congo red is going to be a pink red color. The importance is that under polarized light, the amyloid is giving you a special appearance that is being given the name of a apple green by refringence. And so many ways by which they can ask you a question on amyloid. So they can give you a history of a patient. If you remember the NEET PG 2022 question, they can give you a history of a patient who has undergone dialysis for a long duration of time. So amyloid deposition takes place, especially amyloid beta 2 microglobulin deposition. They have given you a question in which the patient was having some kind of a thyroid cancer and he is having amyloid deposition. So that is going to be associated with medullary thyroid cancer. They gave you a question on something like a cardiac tissue biopsy having the presence of amyloid deposition, because of which the patient was having the presence of restrictive cardiomyopathy. So, the list is just about going on and on and on, but we need to keep in mind about amyloid because that's what I'm going to be discussing with you in immunity section as well. But very, very important image with respect to the questions asked in the exam. Some of the important example of images that are supposed to be kept in mind. So that is what you need to remember over here, that amyloid is going to be staining positively with pass, and the moment you're going to be applying diastase, the color is going to be lost, right? So pass positive, diastase sensitive, just one example to be kept in mind, that is glycogen. The moment we're thinking in terms of an endogenous pigment having a black color, that would be associated with melanin, and melanin is going to be associated or stained with the help of Mason-Fontana stain. You may see Mason, who is an example of a person who is working really hard to make his ends meet. He is the one who's going to be having a dark colored skin, perhaps because exposure to sunlight, much more than you and me. So Mason-Fontana stain is what is going to be useful for the detection of melanin. Of course, that's going to be one of the important images that most of you remember. The extracellular pink color material being deposited so far as the Congo red is concerned, and the same, it is going to be having a presence of a shiny appearance. That's what is going to be given the name of an apple green by refringence, so very classical of amyloidosis. Calcification, another important hot area for exams. Two patterns of calcification, dystrophic and metastatic. All-time favorite for the FMG exam in particular, and sometimes for NEET PG. Whenever you're going to be talking about something like dystrophic calcification associated with dead tissues or degenerated tissues, the calcium levels over here happen to be normal. These can be associated with multiple conditions. Say for example, rheumatic heart disease, atherosclerosis, tuberculosis, or certain types of tumors. With respect to tumors, you just have to remember about the important tumors which are also going to be having, apart from dystrophic calcification, they are going to be having the presence of concentric layers of calcium deposition, which are going to be given the name of semoma bodies. So most of you will be remembering these answers for cracking your PG exams. That's how we remember it. Most of you, meningioma, mesothelioma, O for ovarian serous adenoma, S for salivary gland tumors at time, T for thyroid papillary cancer, P for prolactinoma, and G for glucagonoma. So most of you who are going to be getting decent enough ranks in the exam, not very far away from now, are going to be cramming this particular thing as information. Remember, we have a second pattern of calcification, which is being given the name of metastatic calcification. Metastatic calcification is going to be responsible for causing involvement of normal living tissues, and the reason is the calcium level over here happens to be elevated. So there is a classical hypercalcemia. Now usually it is going to be causing a diffuse involvement of the organelles, but more importantly, there is an involvement of line catcher organelle, that means involvement of mitochondria. What are the conditions where you're going to be having metastatic calcification? So whatever comes to your mind, a condition in which there is increased calcium or a condition in which there is increased phosphate that's likely to be responsible for causing a metastatic calcification. For example, parathyroid adenoma, primary cause of hyperparathyroidism. We are going to be having chronic kidney disease, secondary hyperparathyroidism cause. We can be having the presence of certain types of cancers in which there is going to be PTH related peptide being released. Say for example, lung cancer, especially squamous cell carcinoma. We could be having a condition in which the patient is going to be having the presence of, for that matter, primary hyperparathyroidism. And certain important examples which are never ever to be missed. For example, sarcoidosis. Remember the INI-CET question, which was earlier called as the AIMS question 2018. Sarcoidosis, granulomatous lesion. There is increased activity of 1-alpha hydroxylase, so more calcium. Similarly, we are talking about a condition that is given the name of Williams syndrome. The patients are going to be having increase in vitamin D as well. There can be condition which the patients can be having a situation in which they are going to be suffering from a condition like Paget's disease, or for that matter, patients suffering from multiple myeloma. We could be having it in case of patients who are going to be having a disease that's given the name of milk alkali syndrome. Why should we be forgetting about the final example, which is going to be aluminium toxicity, right? So all those examples of conditions in which there is going to be M for mitochondrial involvement, M for, remember, the patient is having metastatic calcification, right? So that's the examples that we are supposed to keep in mind. Of course, not to forget the fact that the moment we're thinking in terms of calcium deposition, lungs as organs are the commonest site for calcium deposition. Why? Because they are having the presence of an alkaline environment. Do we have some kind of a use of calcium? So related with the knowledge of pharmacology, and you come with an example of an antibiotic which is being used for the labeling index. What is it being used for? It's being used for bone remodeling time. So tetracycline labeling index is what is being used for bone remodeling time. Even that has been asked to you as a question on the exam, and that's a path orthopedics overlap question which I want you to remember from the exam's perspective, right? What's coming next on our exam is going to be example of detection of calcium. Usually very, very fascinating, but thankfully has not been asked in the exam too frequently so far. So in routine staining, calcium is going to be giving you a blue color. So that's a basophilic appearance. That's what we are having a representation over here. But if you're talking about detection of calcium, and it is going to be giving you the presence of a black color. So we talked about the fact, wo kaun sa stain hai which gives calcium a black color. Wo kaun sa, von kosa, giving the calcium a black color. Little amount of calcium, zara sa calcium. You detect zara sa calcium with an example of alizarin red. So alizarin red gives calcium a reddish color, right? That's what is going to be useful. And what you got to go as a question in the exam, azan stain, which is useful. Why? Because it is going to be distinguishing between mineralized bone and osteoid. So that's where you're going to be talking about azan stain. Remember, that's what is going to be important, right? Some example of stains which have been asked at some point of time. I mean, not very regularly asked, but why should we miss out on them if we have the availability of an option of revising them? So one of them can be an example of a stain that is going to be given the name of Messon's trichrome stain. So this is not to be confused with Meson-Fontana, which we discussed earlier. Meson-Fontana, which is going to be associated with detection of melanin. So Meson-Fontana is for melanin. Messon's trichrome. Chrome means color, tri means 3. So it is going to be giving different kind of colors to collagen, to the nuclei, and to the muscle it is present. So why is it being used? It is primarily useful for detection of fibrous tissue, or for that matter collagenous tissue. Over here, Messon's trichrome stain. Remember the keyword over here, collagen. Most important. Then we are going to be talking about something which is given the name of acridine orange. Might be striking a bell in your mind with regards to biochemistry question. Why? Because it is useful for detection of nucleic acids, RNA and DNA. And what are we talking about with respect to something like toluidine blue? So toluidine blue is useful for detection of cells present in the tissue. For example, it is useful for detection of cells which are going to be given the name of mast cells. How was the question asked to you in the 2020 exam? Mast cells are going to be very rich source of histamine, right? And how do we detect them? We detect them with the help of a stain that is given the name of toluidine blue. Toluidine blue, incidentally, is also responsible for detection of the dysplastic cells that can be present in case of an individual. So very, very useful for detection of precancerous lesions. So you apply toluidine blue in the oral cavity, and therefore you are able to pick up the precancerous lesions of the oral cavity as well. So those are the special example of the stains that we are supposed to remember over here. Then we are not supposed to miss out, and that's the example of a stain that we are just making a mention of. So detection of something like the presence of a cancerous lesion in the oral cavity, toluidine blue. Then one-liners that we are supposed to keep in mind, say for example, Sweet's reticulin stain that has been useful for detection of reticulin fibers. Of course, the name is so sweet. Sweet's reticulin stain useful for detection of reticulin fibers, that means typically collagen 3 fibers present in the hepatic tissue. Then we are asked a question exam on Gomori's methenamine silver. So methenamine silver is useful for detection of certain types of fungus. Say for example, the fungal cell wall. And when you talk about something like Gomori's methenamine silver, you might be reminded of certain types of, fungi. Say for example, pneumocystis, right? And we are talking about detection of something like a fungal cell wall. Why? Because when you apply the methenamine silver stain, the fungal cell wall is going to be having a black color. No dearth of the examples over here that is going to be present over here, by which you are going to be having a detection of the fungal cell wall, right? So that is what you need to keep in mind over here. Having said that, let us quickly have a look at different types of instruments and the one-liners which have been asked in the exam. So we have been asked about the different types of instruments, and of course one of the important bread and butters for the professionals, like the people who are going to be in pathology, or for that matter microbiology, for that matter at times even in physiology, right? So we're going to be having the use of something like a microscope, and the microscope is going to be having different types of resolutions: the 10x, which is a low power magnification, the high power magnification 40x, and the 100x, which is going to be the oil immersion, right? Of course, the power is going to be depending, the resolving power is what I'm talking about over here, is going to be depending upon the eyepiece. It is going to be depending upon the power of the lens which is going to be there, and the type of wavelength of the eye. We have been asked questions in the exam with regards to the different components that are going to be having in the microscope, whether it is something like, the condenser over here, whether we are talking about something like the illuminator over here, whether you're talking about something like the nose piece over here, or whether we are talking about something like the head of the microscope over here. So at least the condenser is what you need to be able to pick up. The source of the light, that is illuminator, is what you should be able to pick up. Of course, not forgetting the different types of the lens, objective lens that you're having. So whether it is a low power magnification or a high power magnification or an oil immersion, right? Another technique that has been asked in the exam is flow cytometry, in which you are going to be having the concept of a liquid which is going to be containing cells which are tagged, and then you're going to be using a laser light. You detect the presence of a forward scatter and a side scatter with this. So living cells are going to be having a forward scatter. The cells that are going to be having more granularity are going to be having a side scatter. That is what you need to remember. And how do we represent the flow cytometry? The flow cytometry is being represented with the help of a dot and histogram pattern. Pretty much useful these days, flow cytometry based questions for the detection of lesions. Say for example, hereditary spherocytosis, for lots of detection of something like lymphomas, where you detect for the presence of CD molecules. That is where you are exactly using the flow cytometry. Then we were asked question exam on HPLC, but currently HPLC, which was earlier the investigation, which was a preferred investigation for detection of hemoglobinopathies. Nowadays, if there is an availability, you would be going in for the presence of something like gene sequencing. I mean, gene sequencing is going to be the thing by which you can exactly pinpoint where exactly is the problem present in a patient. Whether we're talking about sickle cell anemia, or you talk about in a patient suffering from something like thalassemia, right? Or for that matter, gene sequencing is what is also going to be useful for any condition where you know that there is some specific genetic defect present in a person and you wish to just confirm it. So that is where you're going to be having the role of the gene sequencing. Of course, that's a machine which is being given the name of a cryostat, which is going to be giving those frozen sections. And the reason is because you want to have a report in a real time, because you have a surgeon who's operating upon a case and he wants to have a tumor-free margin over here. So he would ask you that question. And one of the reasons why we can be using a cryostat is also going to be in case of situations. Say, for example, when we are going to be having a detection of the presence of lipids. Of course, we are going to be using liquid paraffin over here. It is not only about the detection of lipids actually where we are using cryostat, but primarily for the intraoperative report that has to be sent back to the surgeon at the earliest. So that is where you're going to be having the role of the cryostat being mentioned over here, right? The next thing that we need to have an idea is with regards to different types of fixatives which are being used. So we are going to be having what is being given the name of a universal fixative, that is neutral buffered formalin. There can be certain fixatives which suck out water. So they're called as dehydrants. That means ethanol, methanol and acetone. We can be having cross-linking fixatives. For example, formaldehyde, glutaraldehyde and osmium tetroxide. Right? Why there is the importance? Because glutaraldehyde is something that is also useful with regards to electron microscopy. Formaldehyde is something that is very, very commonly used, and as I made a mention of neutral buffered formalin, which is an example of a universal fixative. We can be having what is being given the name of a compound fixative as well. So we can be having an alcohol, we can be having formalin as well. So that is going to be having the properties of both 1 and 2, and that is given the name of compound fixative. One of the areas where you're going to be using the fixatives, especially when they come to your mind and you think in terms of something like a gynecology OPD, would be pap smear. So you have been asked question in the exam, that's a gynae path overlap. How do you you take a pap smear. So there is going to be a retraction of the vagina, and then you're going to be collecting that specimen with the help of the spatula or with the help of that cyto brush. And then you're going to be fixating it with the help of 95% ethanol, right? 95% ethanol. Of course, you're all aware about the techniques, and what are we looking at? We're looking at something like maturation index, which is going to be giving us an idea with regards to the quality of the cells. That's how you're going to be making a report over here. Then with regards to the concept of aging of a cell, which is of course a hot favorite topic these days, we are having the concept of what has been given the name of Hayflick's limit. Remember 2020's question? What is Hayflick's limit? It is a number of times when a normal cell of the human cell population is going to divide before it is going to stop replicating or before it is going to become senescent. So what is Hayflick's limit? The number of times when a cell is going to divide, that is going to be around 60 to 70 times. That's what we need to remember over here. And why that takes place is because as and when the cell is going to be replicating, there is going to be a shortening of the telomere length. So contribution over here is that of shortening of the telomere length, which is what you are going to be observing in the graph over here as well. So somatic cells, over a period of time, the telomere length is going to be reduced. Now, from this important fact, we need to remember that telomere length can be very high or it can be preserved in case of certain types of cells. Classical examples of that would include the germ cells. So gonadal cells or germ cells are going to be having high activity of telomerase physiologically. You are also going to be having sometimes cells which are going to be having development of certain mutations, and then their telomere length is going to be increased. So telomere length is going to be keeping on decreasing in case of somatic cells, but as and when there is a mutation, as and when you're going to be having the presence of a cancer, even they are example of conditions where the telomere length is going to be increased. Why is that important? Point number one, physiological example of cells which are going to maintain their telomere length are going to be germ cells. Pathological example of cells which are going to be having high activity of telomerase is going to be cancer cells. What is the importance of knowing about telomerase? If they are going to be maintaining their length, they'll keep on replicating. They never ever are going to die. So the question asked in the exam is immortality of the cancer cells. I repeat my words. Immortality of the cancer cells are contributed by. And the answer is going to be answered by most of you pretty well now. Immortality of the cancer cells is contributed by the telomerase enzyme. Right? Now, why is this important? This is also important because all of us wish to look young forever. Right? That's a eternal question. I mean, since mankind has emerged. So we do have now the concept of what is being given the name of reversal of aging. Right? So reversal of aging, there can be a lot of theories. I mean, somebody would say decrease oxidative stress, eat lots of sort of fresh fruits. But one of the most characteristic and most important proven theories wherein we are going to be having a reversal of aging is going to be by calorie restriction. There has to be a decrease in the consumption of calories by 30%, which has been shown as per the study in the Harvard University and activity of research at Boston, of course, Professor Sinclair, that there is going to be the presence of reversal of aging. So calorie restriction is one of the known methods of reversal of aging. And how does it contribute? Because calorie restriction is going to increase the activity of certain enzymes, which are going to be given the name of sirtuins. Remember, how many sirtuins were there? INHVD question, more than one option correct question, 7. What activity do sirtuins have? They are responsible for having histone deacetylase activity, contributing to epigenetic mechanisms because of which there is a reversal of aging. I don't want to restrict or cut down on the calorie intake. Do I have something else as a mechanism, at least theoretically? Yes, of course. It has been shown that sirtuin activity is going to increase with the consumption of red wine as well. But of course, cutting down on calories, you would agree, is far better in comparison to consumption of red wine. Mechanism, histone deacetylase activity of sirtuins is going to be responsible for causing reversal of aging. Another important condition which is associated with aging is, unfortunately, at times, you're going to be having excessive DNA damage in case of certain individuals, and they can be suffering from what is being given the name of a premature aging. So one of the important examples can be a condition that is given the name of Werner syndrome. Werner syndrome, in which the individual is going to be having a premature aging because he or she is going to be having a defect at the level of an enzyme that is given the name of helicase. There is a helicase enzyme defect that causes more DNA damage, and that is going to be contributing to Werner syndrome. Mind you over here that this Werner syndrome is not to be confused in the exam with the condition that is given the name of Werner syndrome, which is an example of a condition associated with involvement of multiple endocrine organs. So the moment you think in terms of Werner, multiple endocrine, MNE, multiple endocrine organs are affected in a patient, that is Werner syndrome, whereas Werner syndrome is going to be caused because of an individual who is going to be having too much of a DNA damage. So that's what we need to remember so far as the discussion of this particular topic of cell injury is concerned. This is what is likely to take care of most of the questions that have been asked in all the 3 exams. So make sure that at least you have an idea about all that information that you have discussed in this particular video before you move on to the next one. Right? We now have a look at the important points with regards to the topic of inflammation. Now, when you talk about inflammation, of course, we understand that it is going to be the response of the vascularized connective tissue to any kind of a noxious stimulus. Morphological patterns of inflammation can be various, but the important thing that we have to keep in mind, and that is what they love to ask as a question, is that the catarrhal inflammation is going to be the most common pattern that is seen clinically. We have 2 components of inflammation. One is the vascular component and the second happens to be the cellular component. With respect to the vascular changes associated with inflammation, of course, we understand that vasoconstriction happens to be the first change that is associated with inflammation. This is going to be followed by vasodilation. So let me remind you of a simple 2020 exam question that vasodilation is primarily caused because of release of multiple mediators. But the most important mediator that is going to be playing a role over here is a chemical that is histamine. One of the most characteristic features that we have in case of acute inflammation is increased vascular permeability. And because it is a characteristic feature, so that is referred by the name of the hallmark feature of acute inflammation. There can be multiple mechanisms by which the permeability in case of blood vessel is going to increase. And these can be subclassified as you find them in the table. The mechanism can be, one of the commonest mechanisms is what is given the name of endothelial cell contraction. And this endothelial cell contraction is going to be associated as by the second alternative name of immediate transient response, classically exemplified by the presence of what is given the name of thorn prick in the clinical setup. We do have other mechanisms as well which can be responsible for increased permeability. For example, a direct endothelial cell injury. This is going to be responsible for causing an immediate change in the vascular permeability and present for a longer duration of time. So that is what is being referred by the name of an immediate sustained response. It's immediate and it's present for a longer duration, sustained response. Would be associated with the patient who's going to be suffering from a severe burn injury or might be associated with the presence of a condition like septicemia. Special example of increase in permeability but less commonly observed is something like endothelial cell retraction, which is going to be delayed in nature. However, as you would make mention of the fact that this is going to be seen in case of conditions like association with bacterial infections. Whenever we are going to be talking about an example of a condition like endothelial cell damage, that can be seen because of, say, for example, a patient who has gone to some kind of a beach. Perhaps you would also do it post your exams and having a good result. Late sunburn injury. So you have the presence of a endothelial cell damage. So it is going to be responsible for causing a delayed response and it is going to be prolonged in response so far as the leakage is concerned, and therefore it is given the name of a delayed prolonged response. So those are the other names that you just need to remember only and only when you are preparing for something like the INICT exam. However, for all the exams, whether the screening exam or the NEET PG exam, at least remember the first mechanism because that's the commonest mechanism, that is endothelial cell contraction. Let us not forget that after the increase in permeability, there is a speed reduction of the blood flow and that is going to contribute to the development of stasis. So this stasis is actually going to be responsible for felicitating the clot formation. So this clot formation is facilitated by stasis, and why we say that is because stasis is going to be one of the components of virtuous triad. You got a question 2021, what are the components of virtuous triad? So let me remind you, the most important reason for development of clot formation is endothelial cell injury. Then we are having the presence of altered blood flow. And then we are having the presence of hypercoagulability. Now, out of these the three questions that are coming to my mind as of now, endothelial cell injury is going to be most commonly contributing to development of clot formation. That's question number 1, 2021. We then got a question in the INICT regarding the most common congenital cause of hypercoagulability. That is to be remembered as factor 5 mutation, clotting factor 5 mutation, which is being given the name of Leiden's mutation. Any kind of an alteration in the flow of blood, whether it is stasis or whether it is turbulence, can also result in increased chances of clot formation, right? The second component that we have so far as inflammation is concerned is what is given the name of cellular changes. Now, white blood cells, RBCs and platelets are going to be flowing in the blood. Of course, you know the fact which of them is going to be moving most centrally. The RBCs are going to be moving most centrally. However, when we want to fight infections, we want the cells to move out of the blood vessel. So this process in which the cells are going to be moving out of the blood vessel to the target site is what is given the name of a cellular change. This can have two components as you understand. One can be intravascular cellular changes and the second can be extravascular cellular changes. Now focus on the diagram that is present in your notes as well as what you find on your screen as well. You are having a cell, especially a white blood cell, moving over here. This has to come towards the periphery of the blood vessel. So that's given the name of margination. It is then going to roll over the endothelial cell. So it is going to be given the name of rolling. It attaches itself tightly with the endothelial cell. That's given the name of adhesion or tight binding. And finally, it is going to move out of the blood vessel. So that's given the name of diapedesis or transmigration, right? So this is the exact sequence which was asked to you as an INI-CET 2021 question. We are going to be having margination. We are then having rolling. We are then having adhesion or tight binding. And then we are going to be having the presence of diapedesis. So as we have talked about in the main video, MRAD, or some people call it by the name of MRAT, right? So transmigration, that's going to be the sequence of intravascular cellular changes. Why that is important is clinically because of the fact rolling is dependent upon a molecule that is given the name of silyl X or the molecules that are given the name of selectins. Adhesion or tight binding is dependent upon molecules which are given the name of adhesion molecules, ICAM and VCAM. Any problem in these molecules is going to be responsible for causing increased risk of infections in the concerned patients. If there is going to be a problem at the level of integrins, the patients are going to be suffering from a disease that is given the name of LAD first. I for integrin, I for first, as you find in the Roman numericals. And if there is going to be a problem at the level of silyl X, patients are going to be suffering from what is given the name of LAD second. What is common for LAD first and LAD second is in both these conditions, patients are going to be having increased risk of infections. How will you differentiate that in the exam? In the clinical history, patients having LAD first are the ones who are going to be having the history that there was a delayed separation of umbilical cord. Classically, the umbilical cord in these patients may take around 20 days or even more for separation to take place. So infections plus delayed separation of umbilical cord, that is LAD first, right? If we are talking about the clinical picture of a patient suffering from LAD second, that was incidentally given as one of the FMG exam questions, patients would be having recurrent infections. They would be having the presence of a short stature and they will be having a very, very rare blood group that's given the name of Bombay blood group, right? So that's what we need to remember so far as intravascular cellular changes and the sequence of events is concerned. Now having a look at what exactly is going to be seen outside the vessel. So you're going to be having the presence of chemotaxis, you are having opsonization and you are going to be having phagocytosis. So MRAT-COP, that's what we remember, is going to be the sequence of the cellular changes. Now let's just have a look at the different kinds of salient features as you would be asked in the exam. So this was about margination, rolling is what we talked about, adhesion is what I made a mention of already, and diapedesis is what I made a mention of. But of course, I can always remind you of the fact that diapedesis is dependent upon a molecule that is given the name of CD31 or PCAM molecule. That's a platelet endothelial cell adhesion molecule, which is going to be responsible for causing diapedesis or transmigration. So far as extravascular changes are concerned, the first is the white blood cells are attracted at the site of infection or inflammation under the influence of chemicals that is given the name of chemotaxis. Majority of the chemotactic chemicals are going to be endogenous in nature, but one powerful exogenous chemical that you have to remember over here is going to be what is given the name of bacterial product, right? So endogenous chemicals are going to be including leukotriene B4, you're going to be having interleukin 8 and you're going to be having complement 5A protein, which are going to be responsible for attracting the white blood cells at the site of inflammation. When you're talking about opsonization, you cover the bacteria on all sides, make it tastier. So that is going to be for preferential phagocytosis. And this is going to be done by the molecules like immunoglobulin G. You have a very important role that is being played by C3b. You have a role played by fibrinogen and C-reactive protein. Let us not forget it. When you're talking about engulfment process in which the white blood cell is going to cover up the target bacteria, then this is going to be associated with polymerization associated with involvement of actin. And there is going to be formation of an arm-like structure that's going to be associated with pseudopod formation, which was a previous INI question. When we are talking about the killing, there are two mechanisms by which the target bacteria is going to be killed. One is oxygen independent mechanism, which can use different molecules. Say for example, lactoferrin, which can be using major basic protein, defensins and cathelicidin. I would just remind you of the fact that major basic protein is what we associated with specifically the killing of. It is present in eosinophils and it is specifically going to be associated with having an anti-parasitic action. That's the reason why we mentioned the parasitic infections are going to be having eosinophilia, right? When we are talking about oxygen dependent mechanism, the oxygen dependent mechanism is going to be utilizing powerful enzymes The most powerful enzyme that is utilized over here is NADPH oxidase. You remember the FMG July 2024 question? So that was what was asked in the exam. So NADPH oxidase, which is also given the name of respiratory burst oxidase, is what is going to be used. Another important enzyme that is being used over here is what is going to be given the name of myeloperoxidase, and that is what is going to be responsible for the formation of a very, very powerful free radical, which is given the name of hypochlorous radical. Remember the same radical I discussed with you, which was associated with having the bleaching powder antibacterial property. So these are the examples of the extravascular and the intravascular cellular changes about which we need to have an idea. Now, once we are done with it, let us just have a quick recap of what we talked about earlier. So as I made a mention with you friends, that LAD leukocyte adhesion disorders, if it is LAD first, that's caused because of integrin problem, and there is a history of delayed separation of umbilical cord, recurrent infections, and sometimes the question can make a mention of the patients are going to be having the presence of neutrophilia and minimal pus formation, right? So the neutrophils are not able to adhere to the blood vessels, and therefore there is going to be increased number of neutrophils in the circulation. That explains the neutrophilia. The moment we are thinking in terms of something like the presence of LAD second, that is going to be seen because of a selectin or Siley-Lewis issue. Patients are going to be having short stature, they would be having Bombay blood group, and of course there is going to be a common finding that is going to be recurrent infections. When we are talking about the killing of the bacteria, at times we require the fusion of the phagosome with the lysosome. This is dependent on an enzyme, if you remember from the main videos, List protein. Now suppose there is a defect in the List protein, the patients are then said to be suffering from a condition which is given the name of Shediac-Higashi syndrome. The name itself is what would give you a very good hint with regards to the clinical manifestations. So these patients are going to be having the presence of CNS manifestations, neurological symptoms are seen, increased risk of hemorrhage tendency in the patients because of dysfunction of platelets. There would be decrease in immunity, explaining the increased infections. There is going to be presence of albinism, as can be seen with respect to the color of the skin and hair. Classically, that has been given in case of the questions asked in the exam. And the peripheral smear would show you the presence of such big giant granules, coarse granules within the neutrophils. So once you remember the name, you would automatically remember the features associated with Shediac-Higashi syndrome. Not to forget the previous All India exam question, that the problem in these patients is fusion of phagosome with lysosome is going to be defective. We also associate special example of phenomena over here, which is going to be asked in the exam. That's given the name of cell within cell phenomena. So one example of cell within cell phenomena is what we talked about in association with something like apoptosis, that was caspase dependent program cell death, in which the dead cells were rapidly removed. So therefore they were not able to cause any inflammation. That was given the name of efferocytosis. Remember the role played by C1q, the role played by thrombospondin, right? That's what I want you to remember. The second example of cell within cell phenomena is given the name of emperipolysis. In case of emperipolysis, I just want you to remember the fact that there is going to be internalization of the cell. A live cell would go inside another cell. It will roam around or wander around the bigger cell and then come out safely. So this is going to be a live cell which is going to be moving around after internalization, and this is what is associated with the conditions like autoimmune hepatitis and Rosai-Dorfman disease. Just to cite you an example, as has been given in the image over here, you have the presence of a cell which is given the name of a band cell, right? It is one of the derivatives that you are having in the myeloid series, and this is going to be entering inside a bigger cell that is going to be a megakaryocyte. So what you have over here is there is internalization of a band cell by the megakaryocyte. So this is going to be wandering inside the bigger cell and coming out. So that is what is going to be given the name of emperipolysis. We had a third phenomena which was asked in the INA exam, which you need to remember over here, which is going to be given the name of entosis. Entosis. Now entosis means that you actively target a particular cell. So the cell which is being targeted is a living cell. You actively target it. It is being made to enter inside the cell. Once it is going to enter inside the bigger cell, it is then going to be killed. So the host is actually going to target a cell. It is going to be internalized, and once it is internalized, it is then going to be killed. So it is going to be affecting living cells only. It excludes any kind of dead cells. Remember, in case of efferocytosis, you are only and only talking about dead cells. But over here, you are going to be excluding the dead cells, and then the engulfed cells are going to be killed by the host cell. So the way we remember it is pretty simple. In case there is any confusion, efferocytosis, wo to clear ho gaya, that is going to be only targeting the dead cells. But once you're talking about emperipolysis is you let us say take a visa and you go around here and there. So all our film stars, I mean, they go to some kind of a country, wo wahan se hand pump bhi nikal lete hain. They kill around the people over there, come back safely, right? So live cell goes inside, wanders about, come back, that is emperipolysis. But entosis is best explained on the basis of something like Mahabharata, Abhimanyu. So he was targeted. He was made to enter when he was living, right? And once he entered inside that Chakravyuh, then he was killed. So that is entosis. So quite relatable with respect to the Abhimanyu story, right? Then what has not been asked in the exam so far, but is very likely to be asked in the exam, of course, in the near future, is going to be enclysis. Enclysis is a special term which is being used when the hepatocytes, the liver cells, are going to, capture the live CD4 T cells. So these are the four examples of, as I would say, they are the four examples of cell within cell phenomena. So efferocytosis, emperipolysis, entosis, and enclysis. That's what you need to remember, of course, which is going to be easy for you to pick up in the exam as well. Would be an image-based question asking you about the concept of emperipolysis over here. We now need to have an idea about a special mechanism by which there is going to be a killing of the bacteria, especially when there is going to be a septicemia or when there is a bacterial overload, which is going to be given the name of neutrophil extracellular trap. Now, this is going to be associated with important factors that initially there is going to be activation of arginine deaminase. So there is going to be initially a platelet activation, and then there is going to be activation of arginine deaminase. This is going to be responsible for causing chromatin condensation. What kind of chromatin are you going to be using over here? Please remember, this is going to be nuclear chromatin. You are not going to be using the mitochondrial DNA over here. So that was what was asked to his 2021 exams question, NEET PG, right? What you also need to remember is that in this condition, there is going to be the chromatin which is going to get decondensed. It is going to come out like this, and now it is going to be trapping the bacteria. So there is an entrapment of the bacteria undoubtedly, and that is going to be taking place outside the cell. So extracellular fibrillary meshwork is produced, and that is what is going to be useful for trapping the microorganism, right? Why is that important? Is because once you are going to be having a nuclear decondensation, it is going to be having the presence of antimicrobial enzymes, which is going to be responsible for killing of the trapped bacteria. But the bad point about the story is that this chromatin material now cannot re-enter inside the cell. Once decondensation has taken place, it cannot re-enter inside the cell, and therefore this cell, the white blood cell which was engaged in the process of the neutrophil extracellular trap formation, is also not going to survive. So recall what we talked about earlier. This is what is going to be given the name of a beneficial suicide. So the targeted bacteria and the neutrophil both are going to die. So this is what you need to remember. Fact number 2, once you are going to be having a neutrophil extracellular trap formation, please remember, this is going to be associated with exposure of nuclear antigens. The chromatin material became decondensed, therefore it came out, and now the nuclear antigens are being exposed, and therefore there is a higher risk of development of conditions like SLE as well as other autoimmune disorders, right? What you need to remember, as what was asked to you as an FMG Jan 24 question, neutrophil extracellular trap is unrelated with phagocytosis. So phagocytosis is an independent process. This one is an independent process. This is just at the time of septicemia or bacteremia, which is going to be taking place. So high risk of autoimmune disorders like SLE, development of beneficial suicide. But the good point is that bacteria are going to be trapped and they are going to be killed. We then are asked questions in the exam regards to the important role played by the different kinds of chemical mediators. So one easy question regarding the FMG exam can be with regards to the classification of the chemical mediators, right? The moment we are talking about in terms of preformed mediators, of course, we remember about histamine, one of the key mediators involved in vasodilation. That was the NEET PG 2021 question. Ionized CD21 question. Histamine is present in mast cells, and mast cells are picked up with the help of toluidine blue. The actions of histamine are quite very much replicated by serotonin as well. And we do have the role played by lysosomal enzymes that we talked about in discussion with Nicholas. When we are talking about freshly formed mediators, very important mediator is nitric oxide. One, because it is responsible for causing vasodilation. It's obviously coming from arginine. That's a biochem question. Nitric oxide is also responsible for the formation of free radicals, which are again responsible for targeting the bacteria, right? So peroxynitrite formation from nitric oxide is helpful for targeting the bacteria. The other important ones which are asked in the exam are arachidonic acid metabolites. These are going to be derived from arachidonic acid, which you remember, arachidonic acid was coming from the action of phospholipase A2, biochemistry link over here. And now this arachidonic acid, I must recall over here for you, this arachidonic acid can be acted upon by the COX enzyme responsible for the formation of prostaglandins and thromboxane A2. The thromboxane A2 is going to be responsible for having its source in the platelets. It causes vasoconstriction. It is responsible for facilitating platelet aggregation. When we are talking about other prostaglandins, we need to be familiar with prostaglandin I2, which is also going to be given the name of prostacyclin. It is having exactly opposite action of thromboxane A2. It is coming from blood vessels or endothelial cells, and it is responsible for causing vasodilation as well as it is going to be inhibitory for platelets. So it is anti-aggregatory in nature. We had a mention of other prostaglandins, say for example, prostaglandins D2, E2 and F2 alpha, out of which I shared with you friends, or mentioned over here in the notes as well. PGE2 is responsible for causing very specifically the development of fever as well as pain. So PGE2 causes fever and pain. E for elevation of that body temperature, and E for, remember the fact, E with the sound that you come when there is going to be pain. When there is going to be an action of an enzyme that's given the name of lipoxygenase, this is going to be responsible for the formation of leukotrienes. One leukotriene that I made mention of earlier, leukotriene B4, is responsible for causing chemotaxis. Other leukotrienes are going to be responsible for causing the severe bronchospasm. That's the reason why you have a mention over here that leukotrienes C4, D4, E4 are also being given the name of SRSA. They're example of very powerful bronchoconstrictor agents, right? Of course, we cannot afford to forget the biochemistry question, an easy one, that arachidonic acid is an example of a 20 carbon fatty acid, which is going to be an example of an essential fatty acid, right? So those are the questions which have been asked in the exam with regards to arachidonic acid metabolites. I may remind you that you have certain examples of drugs. For example, steroids are going to act by inhibiting phospholipase A2. The painkillers like NSAIDs are responsible for inhibiting the COX enzyme. Drugs like xylitol are responsible for inhibiting the 5-LOX enzyme. And drugs like montelukast, zafilukast are responsible for inhibiting the receptor. They are leukotriene receptor antagonists, right? When we are talking about cytokines are going to be coming from the cells. They play a very, very important role. That includes interleukin, that includes TNF, and that also includes interferons. These are the example of cellular freshly formed mediators. In the plasma, we have kinin system, complement system, and coagulation system. So before we talk about the mediators present in the plasma, let's quickly have a look at the different types of actions of the cytokines. Now, when you talk about cytokines, majority of the cytokines are going to increase inflammation. So they are pro-inflammatory in nature. Some cytokines are going to be having systemic effects of inflammation. The ones that are present over here on your screen, interleukin 1, interleukin 6, and TNF alpha, right? Out of which important ones are specifically all three of them. Anti-inflammatory action of cytokines can also be seen. Very, very classically, interleukin 10 and TGF beta. Interleukin 10, which was asked you as an FMG question. TGF beta, which was asked you as an INICT November 23 exam question. That's what you need to remember. It is going to be having anti-inflammatory action. And TGF beta and interleukin 10, they also play a very, very important role at the time of wound healing. So after an injury, when you want the scar formation to take place, you obviously would like to reduce inflammation. That's the time interleukin 10, and more importantly, for fibrogenesis, you require TGF beta. That's going to be playing a very critical role. The moment we are thinking in terms of something like cytokines having a dual action, this used to be a favorite for the INI exam at one point of time. We are thinking in terms of interleukin 4 and interleukin 6. So in a lot of conditions, they are having pro-inflammatory action, but sometimes they are said to be having an anti-inflammatory action as well. That's what we need to keep in mind. So far as the interferons are concerned, interferon alpha, beta, and gamma are what we are talking about over here. Interferon alpha is the one which is having antiviral activity. Interferon beta is having immunomodulatory activity, so it is useful in the treatment of a patient having multiple sclerosis. Interferon gamma is what is going to be required for a process of a treatment of a condition that is given the name of chronic granulomatous disease. Remember chronic granulomatous disease? Chronic granulomatous disease, yes, you are aware, is going to be seen because of a patient who is going to be having a trouble in the activity of an enzyme that's given the name of NADPH oxidase. So whenever we are thinking in terms of individuals having NADPH oxidase effect, respiratory burst oxidase effect, these are the patients who are going to be having a high risk of development of chronic granulomatous disease. Remember the microbiology link? What exactly is going to be the name of the test by which you make a diagnosis of chronic granulomatous disease? So we do a test which is given the name of, very good, you remember that? The smile on your face tells me that you are feeling confident now. This is nitroblue tetrazolium test. Nitroblue tetrazolium test. Of course, we have another test which was asked in the FMG exam, which is given the name of the dihydrorhodamine test. So nitroblue tetrazolium test and the dihydrorhodamine test is what you need to remember over here. The way they asked you the question in the screening exam was the fact that patients who are going to be having chronic granulomatous disease, they are more commonly going to be having catalase positive organisms causing infection in them. So pretty much commonly the infections are caused by organisms like Staph aureus or Burkholderia, or for that matter Candida. Catalase positive organisms cause infection in patients suffering from chronic granulomatous disease, right? We are going to be talking a bit about chemokines as well, in which alpha chemokine, which is interleukin 8, is important because that is responsible for attracting neutrophils. Beta chemokines would include eotaxin that attracts the eosinophils. eosinophils incidentally are also being attracted by a cytokine that's given the name of interleukin 5. That's what you need to remember over here. Of course, we are going to be talking about lymphotactin, which is going to be attracting the lymphocytes, right? And then we are going to be having the presence of the CXC chemokines, which are important usually for the type purpose of inflammation, as well as we have talked about the CXC R4 and CXC5 with respect to CCR5 with respect to a virus that you read in microbiology. That's a HIV virus. So responsible for facilitating the entry of the virus inside the host cell. Then talking about the chemical mediators which are going to be present in the plasma, just wrapping up about kinin system. So activated by the presence of factor 12, that's a Hedgeman's factor, and this is going to be responsible for the formation of kallikrein. The kallikrein is going to be responsible for the formation of bradykinin. Why do I want you to remember about bradykinin? Because bradykinin is going to be responsible for causing increase in permeability, as well as it is going to be contributing to the development of pain. We talked about the pharmacological correlation as well. Increased bradykinin is going to be responsible for causing dry cough, one of the important side effects that you associate with drugs like the ACE inhibitors. The moment we're thinking in terms of the complement system, can be activated by the classical pathway, the alternate pathway, or the lectin pathway. Commonest usually happens to be the classical pathway, in which you are going to be having the involvement of both antigen as well as the antibodies. We are going to be talking about the alternate pathway, very much important so far as infections caused by gram-negative bacteria are concerned, as well as the presence of an exposure to something like snake venom, right? In case of classical pathway activation, the role is being played by IgM and IgG antibody. In case of alternate pathway activation, the role is being played by IgA antibody. And of course, we are going to be having a role that is being played by the lectin pathway as well. Whether it is a classical pathway or the alternate pathway or the lectin pathway, the good point is all of them together are going to be responsible for causing the coming together point is the breakdown of C3. Now, C3b is what is going to be functioning as an example of opsonin molecule. That's what we talked about earlier. And the moment we are thinking in terms of the other individual complement proteins, we should be aware of the fact that C5a and C3a are responsible or functioning as anaphylotoxins, right? So they are responsible for causing degranulation of the mast cell as well as responsible for release of histamine. C3b, as I just now made a mention, is responsible for preferential phagocytosis by the process of opsonization. And importantly is that towards the end, the complement system is going to be working eventually by the formation of what is given the name of MAC. Remember MAC, membrane attack complex. So we had a formula for MAC, C5b-9 complex, and this is what is going to be responsible for causing, boom, the lysis of the microorganism. We do have regulatory molecules as well for controlling the activity of the complement system, on which questions were asked in the exam. So quick look regarding the importance of these molecules. If there is a deficiency of individual complement proteins, say for example C1, C2, C4, they are called by the name of early complement proteins. Patients are always at high risk of development of autoimmune disorders, especially SLE. Very, very commonly asked question in the exam, especially the NEET PG and the screening exam. C3 deficiency is going to be responsible for causing high risk of pyogenic infections. Any deficiency of the late complement proteins, C5, 6, 7, 8, that's what is going to be reminding you of infections caused by Neisseria organism and toxoplasmosis. So whether we are talking about Neisseria gonorrhea or whether we talk about Neisseria meningitidis, gram-negative diplococci, as well as toxoplasma infections, more commonly with C5, 6, 7, 8 deficiency. Interestingly, if there is any kind of a defect at the level of C9, it is not going to cause any disease. There is no disease because of C9 deficiency. Once we are talking about the regulatory molecules, we need to have an idea about the one which was asked in the question of the exam, C1 inhibitor, 2022's question. This is going to contribute to the development of hereditary angioedema. So patients are going to be having a history of swelling of episodes of their oral mucosa. The lips can be involved, the tongue can be involved, the oral mucosa can be involved. So that can be because of C1 inhibitor deficiency. Another one that we need to remember over here is going to be patients who are going to be having CD55 and CD59 defect. They are the ones which are going to be suffering from RBC, intravascular hemolytic disorder, that's given the name of the paroxysmal nocturnal hemoglobinuria, right? Whenever we are going to be talking about PNH, I hope you're reminded of the fact it's an example of an acquired disorder, and there is going to be a problem which is going to be seen that this is going to be associated with intravascular hemolysis, right? When we are talking about factor H and factor I, complement regulatory protein deficiencies, they are going to be responsible for causing a high risk for development of atypical hemolytic uremic syndrome, right? So those are the important regulatory proteins about which you need to have an idea so as to crack the questions that have been asked in the exam. We also need to be familiar with the fact that one of the INICT questions, if there is going to be a complement protein deficiency, then live vaccines, mark my words, live vaccines are not contraindicated. Live vaccines are not contraindicated even if there is a complement protein deficiency, right? The moment we are thinking in terms of coagulation cascade, one of the most often asked topics in the exam, of course, we are reminded of the sequence of the coagulation cascade, whether we are talking about the intrinsic pathway, wherein we talk about the activation of factor 12, then 11, then 9, then 10, then prothrombin to thrombin, fibrin erosion to fibrin, and then stabilization of the clot. Or we are talking about something like the extrinsic pathway, which is going to be associated with tissue damage, responsible for causing activation of factor 7 and then activation of factor 10 and subsequently the same story. Interestingly, what you need to remember over here is that whenever we are talking about the formation of a clot, a stable clot is going to be produced only and only by factor 13. So stabilization of the blood clot is a function of factor 13. We have been asked questions in the exam regarding the half-life of the different clotting factors. Some of these clotting factors are going to be dependent upon vitamin K, as you can just quickly have a look at this. Vitamin K dependent factors would include factors 2, 7, 9 and 10. Pregnancy is a very important physiological hypercoagulable state. Why? Because all the clotting factors are going to be increased in pregnancy. But there are certain clotting factors which do not increase at the time of pregnancy. Examples of which would include factors 11 and factor 13. They are paradoxically going to decrease at the time of pregnancy. Another important thing that we need to remind ourselves over here is with respect to the role played by factor 5. Now, factor 5 is what I want you to remember. It is under the influence of protein C and protein S. So, protein C and protein S can inhibit the activity of factor 5. However, there can be people who are going to be having the presence of factor 5 mutation, which is going to be given the name of Leydon's mutation. The moment we are thinking in terms of something like Leydon's mutation, that's important because now factor 5 is going to be responsible for acting as a very strong pro-coagulant factor. So, during Leydon's mutation, factor 5 is not going to be under the inhibitory control of protein C and protein S, and therefore, the Leydon's mutation, please mark my words, is the most common inheritable cause of hypercoagulability. It's the commonest inheritable cause of hypercoagulability. They may ask you what's the reason, because at the delta 506 position, there is a replacement of arginine by glutamine in this situation. When we are talking about the monitoring of the intrinsic pathway is going to be done with the help of APTT, that is activated partial thromboplastin. And the monitoring of the extrinsic pathway, please remember friends, is going to be done with the help of prothrombin time. Instead of prothrombin time, as most of you are aware, clinically, what we are preferring to use nowadays happens to be the International Normalized Ratio or INR. For the purpose of calculation of PT and APTT, what we are using over here is preferably the use of a plastic syringe. As you can understand, that plastic syringe is what is to be used, and within 2 hours of the sample collection, we need to remember that we are going to be performing this kind of a test. However, you do not want the blood sample to clot prematurely. Therefore, you would like to add an anticoagulant over here. And what's the preferred anticoagulant over here? That's going to be 3.2% trisodium citrate. INICT people would love to ask you the name of the vacutainer that is going to be used by you when you wish to use 3.2% trisodium citrate. So I would just remind you the fact that the vacutainer that is going to be used by you is going to be the one which is going to be having the same color that I'm using now, just so that you remember it, mentally. It is going to be an example of a blue top vacutainer, right? Blue top vacutainer, which contains trisodium citrate and therefore useful for estimation of prothrombin time and APTT values. So those are the things which are supposed to be kept in your mind so far as a question in the exam are concerned regarding this. Now, one interesting question is that which clotting factor is not going to be, affecting the clotting in vivo, even if it is going to be deficient. So that is what you need to remember. The answer is factor number 12. So factor 12, even if it is deficient, it is not going to be affecting clotting in vivo in any which way. So lots and lots of questions in the exam with regards to the coagulation cascade, which we are supposed to keep in mind. And overall, if you look at the number of questions with regards to the inflammatory mediators, whether it is the pre-formed mediators, the freshly formed mediators, or the mediators which are present in the plasma, you definitely get at least one question in every exam, be it the NEET PG or be it the FMG exam from these ones, right? Indirect questions in the INICT are also going to be seen. Now, having said that, we need to have an idea about the longer duration inflammatory process, which is going to be given the name of chronic inflammation. And chronic inflammation is going to be characterized by an important feature that is going to be tissue destruction or damage. So there is an ongoing inflammation. The body is trying to take care of that inflammation, but there is also going to be a tissue destruction which is going on, right? What we are talking about in chronic inflammation, some of the examples of chronic inflammatory conditions are going to be having the presence of a granuloma formation. And those conditions are going to be given the name of granulomatous disorders, and lots of them that you need to keep in mind. Tuberculosis, leprosy, Crohn's disease. You're going to be talking about different types of granulomatous vasculitic disorders. That's what is to be remembered. Now, in case of certain examples of granulomatous disorders, please remember that you would be having a role that is going to be played by modified macrophages. So from the perspective of an easy question, different cells in the tissues in the body have been given special names when we are talking about modified macrophages. A lot of you know the examples. No, in the kidney, you are having the presence of mesangial cell. Liver, you would be having Kupffer cell. In the placenta, very commonly asked in the exam, you are having the presence of a Hofbauer cell. Bones would contain the osteoclasts. Spleen contains littoral cells, the ones responsible for, picking on your RBCs once they are old. Microglia present in the brain, and you are having the presence of type A cells which are present in the synovium. What you are asked in the exam these days is, however, different examples of granulomas, maybe with the clinical history or maybe with specific shapes or features that they are having. Let's just look at the image to understand this better. So in case of tuberculosis, we had a discussion. We are having the presence of caseous necrosis. We are also having the presence of a granuloma formation. So they'll talk about a history of a patient who's having presence of fever, cough, cervical lymphadenopathy, right? Or perhaps maybe hemoptysis. And then on the lung biopsy, you would be having the presence of a caseating granuloma. How would you make out a caseating granuloma? In a lot of questions in the exam, you would be having the central area, which is a pale area associated with caseous necrosis. You would be at times going to be having the presence of images. I believe you are going to be having better ones once you see at the PYQs, which are going to be having the presence of the giant cells over here, which are going to be having the presence of the horseshoe shaped nuclei. And usually you're also going to be having a collar or a ring of lymphocytes over there, right? So that is what is going to be seen as a feature of a patient suffering from tuberculosis. The moment you think in terms of a condition which is very, very similar to tuberculosis, which is given the name of sarcoidosis, sarcoidosis is having the presence of a naked granuloma. What that means is, you're going to be having a granuloma formation over here. Of course, there is a granuloma formation over here, but you do not have the classical ring of the lymphocytes over here. So there is very few or minimal lymphocytes over here. That's why it appears to you that the lymphocyte cover is not there. Without cover, the granuloma appears naked. That's the reason why you call it by the name of a naked granuloma. Special example which was asked in the 2019 exam was about malaria, especially Plasmodium falciparum malaria, wherein you are going to be having the presence of a perivascular granuloma, which is given the name of a Dirk granuloma. Of course, you need to be familiar with the fact you are using a special kind of a stain over here, which is being given the name of a field stain. So that is what it should be remembered so far as the Dirk granuloma is concerned. Other ones which have been asked in the exam, especially NEET PG, are going to be the star-shaped granuloma, which is going to be given the name of a stellate granuloma. The term stellate granuloma is what you associate in a patient associated with cat scratch disease. Something which will bring you a question in your mind with regards to the etiological factor or the vector over here. The donut-shaped granuloma, and this one is going to be associated with the Coxiella infection. So we are talking about over here what is given the name of Q fever. So donut granuloma, Q fever. Again, reminder of a gentle 2020 exams question. Finally, we are going to be talking about a condition that is going to be given the name of syphilis. In case of syphilis, you are going to be having the involvement of the blood vessels and the granuloma associated. The special term mentioned in the exam question over here is going to be gamma, right? So those special terms are what you need to keep in mind so far as the different types of granulomatous lesions, be it their feature, be it their shape, are concerned. Once we are through with that, we need to have an idea about the different types of giant cells. Remember giant cells? Lots and lots of macrophages come together, fuse together. So they are responsible for the formation of multinucleated big cells. Those are given the name of giant cells. So when we are talking about giant cells, of course, no discussion can ever be complete if we don't talk about the Langerhans giant cell. That's going to be seen in a patient suffering from tuberculosis. And that's a kind of a pattern that you will be having. So you're going to be having the nuclei arranged in a horseshoe pattern in the periphery. So it can be in a inverted U appearance, that's called as a horseshoe appearance, or that can be given the name of a necklace pattern that is very, very typically seen in case of tuberculosis. Foreign body giant cell, please remember, is going to be associated with the presence of multi-nucleated cell, but it is not going to be arranged in a specific pattern. So it is a haphazard pattern. Might be seen in association with, let's say, a talc associated granuloma or a non-absorbable suture associated granuloma, classical examples of which are asked in the exam. Then we are going to be talking about a giant cell that you read in microbiology, which is given the name of Warthin-Finkelday cell. So we'll be reminding you of an unimmunized child having fever, coryza, sore throat, having the presence of a Koplik spot, and this patient is going to be having the presence of an atypical pneumonia. Remember, Hecht's pneumonia is a term that you're using. You're going to be having the presence of the intracytoplasmic intranuclear inclusions caused by the viral particles. That's given the name of a Warthin-Finkelday cell. Warthin-Finkelday cell, right? So those are the three examples present as of now on this page. And of course, no discussion can ever be complete, especially in an Indian exam or any global exam, if we do not talk about something like Reed-Sternberg cell. Reed-Sternberg cell, classical examples of binucleated cells, which are going to be seen in a patient who's going to be suffering from a condition like Hodgkin's lymphoma. You're going to be having the cells which are going to be having the presence of those wonderful eosinophilic inclusions, as you can make out that beautifully, and that is going to be seen in a patient suffering from Hodgkin's lymphoma. Of course, I would be happier to remind you of the fact that this owl eye appearance is not the characteristic way of diagnosis of a Reed-Sternberg cell. You would still rely on flow cytometry. You would still rely on the determination or documentation of CD molecules, CD15 and CD30, so as to confirm for the presence of Reed-Sternberg cell. When we are talking about Patho1 giant cell, remember it is seen in case of xanthoma. So you would be having the presence of that whitish appearance, foamy appearance of the cytoplasm because of the lipids. And you're going to be having the nuclei which are going to be arranging themselves separated out in the periphery, right? So that's going to be an example of a Patho1 giant cell. When you're talking about an osteoclastic giant cell, might as well remind you of something that you have been told in orthopedics as well, is going to be seen in a patient suffering from osteoclastoma or a giant cell tumor of the bone. Giant cell tumor of the bone, right? So those are the important examples of the different types of giant cells which have been asked in the exam earlier. Now, once chronic inflammation has taken place, the wound has to heal, and therefore we need to have an idea about the concept of wound healing. With respect to wound healing, they've asked you the important features which are going to be associated with different days of wound healing. So usually on the very first day, the day 0, the clot is going to be formed. Within a short span of time, you would be having neutrophilic infiltration over here. There is going to be a thin epithelial cover on day 2. And the characteristically feature that is going to be seen over here is granulation tissue is going to be appearing on day 3. As time passes, amount of granulation tissue is going to increase, right? What you need to remind you over here is collagen is going to be becoming increased with increased amount on subsequent days, and you're going to be having the presence of maximum angiogenesis over here. Then around 2 weeks, you're going to be having increase in collagen as well as with respect to the fibrous tissue. Now, how would they ask you a question? They can ask you a question because once a wound is going to be healing, you require lots and lots of blood vessels. So you can actually make out the presence of lots and lots of those vascularized tissue that is going to be present over here. And the interstitium is going to be having the presence of the fibroblasts, right? Apart from this, there are going to be theoretical questions which will ask you, as what they did you in the 2020 exam. They ask you about the concept of collagen remodeling. So initially, the collagen that is going to be deposited is going to be collagen type 3. This is over a period of time going to be replaced by collagen type 1, which is an example of a zinc dependent process. Why? Because the enzymes involved over here are matrix metalloproteases. So metalloproteases, they would be requiring a metal. And of course, one of the important cofactors required over here is zinc, which explains the fact that if there is a zinc deficiency, the wound healing process cannot take place properly, right? Once you're talking about the concept of scar contraction, that is primarily because of altered fibroblasts, which are given the name of myofibroblasts, which are going to be having a contractile property. So they are responsible for causing a decrease in the size of the scar. Another important thing to be kept in mind is pertaining to the strength of a wound. The strength of the wound after about 1 week of an injury is just about 10%. It is going to be around 70% by the end of 3 months. And as time passes by, the strength of the wound is going to keep on increasing. But never ever it is going to be reaching 100%. So the examiners have been courteous enough, especially for the screening exam. They still would love to ask you questions on these kind of data, that what exactly is going to be the strength of the wound after about 3 months or perhaps after about 1 week, or what exactly is going to be the time when the strength of the wound is going to be reaching 100%. The answer is, of course, it is never ever going to be so, right? So that is what you just need to have an idea so far as the concept of wound healing is concerned. Now, of course, there are going to be people not as lucky as you and me who are going to be having an altered form of wound healing, which is again going to be an important area which is going to be asked in the exams. And the classical examples of abnormal wound healing can be including a condition that is given the name of hypertrophic scar. This was asked to you as a NEET PG exam question 2018. And these patients are not to be confused with patients who are going to be suffering from another abnormal example of wound healing, which is given the name of keloid. So the images are what are going to be known to you, but perhaps you just need to quickly have a recap with regards to the findings over here. With regards to keloid, I must remind you that patients are going to be having a genetic predisposition. So more commonly seen in case of Africans, it is most commonly going to be located in the skin overlying the sternum. However, it can be seen with patients after they are going to be going in for an ear piercing procedure as well. For that matter, nose piercing procedure as well, right? And there is going to be no spontaneous regression so far as a keloid is concerned. The problem with the keloid is that you are going to be having collagen, which is present in extra amount, but it is going to be arranging itself in a haphazard fashion. So as I always talk about that fact that there is going to be the problem with the keloid is keloid wants everything. It wants to cover everything. So it doesn't respect boundaries. So it is going to overgrow all the wound boundaries, vertically as well as horizontally. That's a problem with the keloid. And that's why it is going to be so disfiguring so far as a concerned individual is seen. Now, when you're talking about a keloid, we have to reduce the proliferation of the fibroblasts, which can be achieved with the help of a drug like a steroid, especially we're talking about a intralesional triamcinolone injection, right? So that is going to be your pharmacology general surgery link as well. If we are talking about something like hypertrophic scar, there is going to be no genetic predisposition. There is going to be no specific site on which you're going to be having it. And the good point about hypertrophic scar is at times you would be having the presence of a spontaneous reduction in the size as well. Hypertrophic scar in that sense is relatively good because it still respects boundaries. What I mean by that is that it is going to be still present within the boundaries. And perhaps one of the reasons is because the collagen fiber deposition in case of the hypertrophic scar is in the form of a parallel deposition. So presence of a zigzag or a haphazard arrangement or a thick kind of a, I would say, collagen fiber deposition can be seen in case of keloid, whereas relatively parallel and thinner collagen fibers deposition is going to be seen in case of hypertrophic scar. May I just remind you the fact what I discussed with you in the initial section of this particular video only. What is an example of a stain which can be useful for picking up the collagen? Yes, you're very right. That's given the name of the Messon's trichrome stain. Remember, we discussed it is not to be confused with the Masson-Fontana stain that is useful for picking up something like melanin, right? So that's what is going to take care of our discussion so far as this important topic of inflammation is concerned. So in continuation of our discussion, we now talk about the topic of hemodynamics. Now with respect to hemodynamics, one of the most often things which is being asked in exams is from the topic of embolism. And as we understand that any piece of a detached solid, liquid or gaseous particle which is going to be moving from its initial site of formation to a distal site is what is being given the name of embolism, right? Now, one of the most important reasons of this question being asked in the exam is with respect to the clinical situation that the examiner is going to be giving you from the topic of pulmonary thromboembolism. And when you talk about pulmonary thromboembolism, it is just going to be a gentle reminder of the fact that it is going to be primarily arising from the deep vein thrombosis. As has been asked in the previous NEET PG exam, especially 2018 and earlier years, that majority of the pulmonary emboli are going to be clinically silent. However, they become significant when there is going to be more than 60% of obstruction because that can be responsible for causing a development of a sudden cardiac death. So you also get an image-based question in the exam wherein you are going to be having the presence of a clot, as you can make out over here. And this is what is going to be seen as an autopsy finding. So classical, they'll tell you about a history of a person, a patient who has been admitted in the hospital for a long duration of time, because of which he had a development of deep vein thrombosis. And one fine day, he was having a development of a dyspnea, or he was found to be, suddenly he was found to be dead in his bed. So that is what is going to be associated with the presence of a massive obstruction, and that can be attributed to the development of a pulmonary thromboembolism. We do have a situation wherein at times the clot is going to be responsible for causing occlusion of the pulmonary artery bifurcation, and we have a special term that is associated for such kind of emboli, that this is what is going to be given the name of a saddle embolus. What exactly can be the investigation can be part of a clinical history based question, which is going to be answered by you in the exam as one of the preferred investigations is CT pulmonary angiography. And one of the classical findings that they would give you in a medicine question would be what exactly is going to be the ECG finding of a patient suffering from pulmonary embolism. So that is either going to be sinus tachycardia, but a characteristic finding that is led by the examiners for the MCQ exam is the S1Q3T3 abnormality. So that's an important thing that you need to remember so far as a pulmonary thromboembolism is concerned. Now, one of the causes of concern with respect to the obstetrics ward happens to be a condition that is going to be given the name of amniotic fluid embolism. And why that is important is because this is going to be a very important reason for development of maternal mortality in the postpartum period. The unfortunate part of the story is that majority of the people who are going to be having the development of amniotic fluid embolism will not survive. Even for the small fraction of the survivors, they are going to be having the presence of some kind of a neurological deficit. So that's a very, very important thing that you need to remember for the exam perspective, that overall it's a very bad condition for any individual to have. Now, this can have a presentation in the form of a classical history wherein the lady is going to be giving rise to birth of a baby, and then she is going to be having a development of a severe dyspnea, or it can be having a presentation in the form of DIC. How exactly would you pick up this question in the exam is going to be based upon the histological findings, wherein the amniotic fluid is going to be entering into the maternal circulation, and therefore the question will classically talk about the presence of something like the squamous cells, which are going to be coming from the fetal skin, or the lanugo hair, or the fat, or the mucin, which is going to be entering inside the maternal pulmonary blood vessels. So classically you would be having the maternal blood vessels, which are going to be showing you the presence of the fat. They could be having the presence of hair. They could be having the presence of the fetal squamous tissue, and that is going to be responsible for causing the trouble in the patients. So bad condition overall for the individual concerned, for the lady concerned, because that is going to be responsible for causing morbidity or a high rate of mortality. Another condition that has been asked in the exam with increased frequency is a condition that is being given the name of fat embolism. Classically is going to be seen because of a history of a trauma or an accident, and that is going to be associated with the fracture of the long arm bones, or very uncommonly it can be seen in case of a patient who's going to be having a soft tissue trauma. Beyond accidents, another common cause of development of this condition can be a history of a burn injury in the patient. In complete contrast to amniotic fluid embolism, if you look at this kind of a condition, less than 10% of the individuals are going to be symptomatic, right? So again, predominantly an example of a condition in which the symptoms are not going to be developing. But what you need to remember over here is that the diagnosis is going to be based upon what is going to be given the name of the GERD criteria, right? GERD criteria, that's what is to be kept in mind. And what we are going to be having over here in patients having fat embolism would be, there would be classically an example of a decrease in the oxygen concentration in the blood. There would be a presence of a petechial rash in the skin, and there would be presence of neurological features in addition to the development of anemia. So patients are going to be having a petechial rash, they will be having anemia. There is a neurological deficit, and the patients are going to be having the presence of hypoxemia as well. In the histological picture, because there is a presence of a fat embolism, so you expect to have fat globules which are going to be seen histologically. Now, essentially, please remember the concept, fat is going to be washed off, and therefore you are going to be having an appearance which is going to be the empty looking appearance of the globules that are going to be seen in the circulation in the examination. So that's why you have a mention of the fat, clear looking vacuoles which are going to be seen on the histological examination of the pulmonary tissue over here, right? The other one that we need to remember over here is an example of a condition that is going to be air embolism. Now, the classical history which was given to you or told to you way back in the physiology classes was the fact that air can be entering, especially in case of certain types of professional individuals, say for example the deep sea divers, or for that matter the scuba divers, right? So any kind of a scuba diving accident or any kind of a deep sea diver, they were the ones who are going to be suffering from it. But the other important example which I specifically want you to keep in mind is, as and when, let us say you as a first year PG resident, or you are working as a JR, or you are working in the ICU setup, and you try to insert a central line, very classical history, insertion of a central line, and that is what is going to be responsible for inadvertent insertion of air inside the pulmonary circulation. So that's what is going to be given the name of air embolism. Of course, when we are talking about the scuba diving accidents, or when we are talking about traumatic injuries, that is what is going to be also kept in mind by you. How exactly is going to be this condition mentioned? That is going to be on the basis of a hyperbaric oxygen that is going to be required, so that the bubbles of the gas, they go back into the vessel, they go back into the circulation, and then you are going to be having a slow decompression. That's how you are going to be taking care of the people who are going to be suffering from a condition that is given the name of Kaison's disease, right? The other examples which have been asked relatively infrequently, just a one-time topic which has been asked in the IRICT has been on vegetable aspiration, wherein they gave you a history that the person concerned was eating his food in a hurry, and then he suddenly had a development of a dyspnea and he collapsed, right? And then his pulmonary biopsy was showing you the presence of a refractile material which was suggestive of the vegetative material that he had aspirated. And because of the inflammatory reaction to the vegetative material, he had the presence of a foreign body giant cell. So you could actually see for the presence of the foreign body giant cell over here, the cell which is going to be having the presence of multiple nuclei over here. And sometimes you're going to be having that pinkish hyaline refractile material, which is going to be suggestive of the food material which has been aspirated by the concerned individual. One of the most important topics which has made a comeback, so to say, with respect to the exam questions from 2021 to 2024, right, has been nutmeg liver. Now, nutmeg liver refers to simply the variegated appearance of the liver that you have over here. So you're going to be having the dark and the light areas on the cut section of the liver. This is classically going to be associated with venous congestion. Point to be remembered, however, over here is that this is going to be seen as a feature of chronic venous congestion, not acute venous congestion. And therefore, one of the common conditions which can be associated with this condition is going to be right-sided cardiac failure. Right-sided cardiac failure is what you need to remember over here. Now, what exactly is going to be the reason for the variegated appearance? Because we are going to be having the presence of the dead cells which are going to be appearing darker in color. And therefore, these cells are going to be given the name of the centrilobular hepatocytes. And we are going to be having the lighter areas. The lighter areas are actually going to be the living cells. So we have made a mention of this, D and D, D for dark, and they are going to be centilobular, whereas the cells which are going to be living are going to be the light appearing cells. They are the living cells, and they are the ones which are going to be present around the portal triad. So they are going to be associated with the term periportal hepatocytes. So pretty important image from the exam's perspective, which has to be kept in mind so far as the appearance of the liver, the nutmeg liver, is concerned. So that's a short and sweet discussion that we need to have an idea from the topic of hemodynamics. Of course, I would want you to remember the fact that when we are talking about hemodynamics, we are going to be having certain conditions which are going to be associated with increased risk of coagulation. These can be examples of congenital causes of hypercoagulability, and let us not forget what we talked about earlier as well, perhaps, that the most common inheritable cause of hypercoagulability is going to be a condition that is going to be given the name of Leydon's mutation. So Leydon's mutation, in which there is going to be an arginine to glutamine substitution at the level of 506 codon. This is what is going to be responsible for causing the development of protein C and protein S, which are not going to be responsible for inhibiting factor 5. So Leydon's mutation is a factor 5 mutation. Normally, protein C and protein S are responsible for inhibiting the activity of factor 5. But once there is a Leydon's mutation, factor 5 cannot be controlled by protein C and protein S, and therefore it is going to become hyperactive. And that is what is going to be responsible for causing an increased risk of coagulability in the patients. So that's what we need to remember so far as the short and sweet discussion of hemodynamic topics is concerned. Right, so we now have a discussion about a very important topic, and that is the topic of immunity. Now, when we talk about immunity, as we understand, there can be two arms of immunity. One which is given the name of innate immunity, the one which is going to be absolutely the first line of defense. It's non-specific and it is not having the presence of a memory. And the second arm, which is going to be the adaptive immunity, which is going to be much more specific, as it is going to develop after exposure to antigen, and memory is also going to be present. Now, when you look at the components of innate and adaptive immunity, let us just revise that innate immunity is going to be associated with presence of epithelial barrier. Say, for example, skin. We are going to be having the role that is going to be played by different types of cells, amongst which we have important cells like the phagocytic cells, neutrophils and macrophages, dendritic cells, and we have cells which are given the name of natural killer cells. Serum proteins are going to be playing an important role in case of innate immunity as well. But one example of a group of proteins, which is a complement protein, is going to be a bridge between the innate immunity as well as adaptive immunity. When we are talking about something like adaptive immunity is contributed by primarily cells like the B lymphocytes. Why? Because they secrete antibodies. That's why you're going to be associating them with the term humoral immunity. And you're going to be having a second arm, which is going to be given the name of T cells, which are going to be contributing to the effector T cells and therefore contribute to cellular immunity. Now, please understand the fact that there is one particular group of T cells which are going to be a part of innate immunity, and these T cells are going to be given the name of the gamma delta T cells. When we are talking about the innate immunity, there are certain types of molecules which are going to be associated with the defense mechanism, and important amongst them would include structure which is given the name of inflammasome. So inflammasome is responsible for association or recognition of the danger associated molecular patterns, and that is what is going to be associated with recognition of the dead cells, the microorganisms, and the uric acid. Activation of the cells is going to be associated with the involvement of the toll-like receptor, and this is going to be acting by the mechanism of the nuclear factor kappa beta, because of which you are going to be having the activation of the antigen. As I was making a mention with you, why do we need to talk about the gamma delta T cells? Because they are example of intraepithelial cells. They are example of intraepithelial cells, and these gamma delta T cells are going to be associated with the fact that they are going to be responsible for fighting, or they are going to be a very good defense against mycobacteria. How are they going to be different from the regular T cells? Because they are, one, not a part of innate immunity. Second, they are going to be required for the presentation of lipid antigen. And fact number 3, they do not require MHC protein for the presentation of the antigen. Let's have a quick look at the important types of cells with the CD molecular markers. So we need to have an idea about the cells like the T cell, which is going to be having an expression of molecules like CD1 to CD8. Of course, we all understand CD3 happens to be a pan T cell marker. T cells also express co-stimulatory molecules, one example of which happens to be CD28. A second example of which happens to be CD40 ligand. If I'm talking about something like the B cells, we need to be familiar with CD19 to CD23, 19, 20, 21, 22, 23, specifically with CD19 being a pan B cell marker, and CD21, which is going to be a entry receptor so far as Epstein-Barr virus is concerned. Co-stimulatory molecules are present on the B cells as well, and that would include molecules like CD40, CD80 and CD86. Easier for us to understand when we are talking about molecules like CD40, this is what is going to be interacting with the CD40 ligand molecule on the T cells, and CD28 molecule is going to be interacting with CD80 and CD86. We'll have a discussion about this again in a few minutes down the line. The moment we are thinking in terms of a cell which is going to be given the name of the NK cell, NK cell is going to be having a presence of markers like CD16, CD56 and CD94 expression as well. The moment we are talking about identification of megakaryocytes or platelet precursors, we identify them with the help of CD41 and CD61. When we are thinking in terms of memory cells, memory cell is going to be identified with the help of CD45RO. But this is what is to be read cautiously by you in the exam, friends, because if the question in the exam is asking you about CD45, then this is referring to the leukocyte common antigen or the LCA. So I repeat that CD45RO is for memory cells, CD45 is for leukocyte common antigen. Having a quick recap about the different types of antibodies which are a component of the humoral immunity. The antibodies, as we understand, are present in a descending order of concentration, which can be remembered with the acronym that is GAMD. When we are talking about the most abundant antibody, that is IgG antibody, it is going to be important for the secondary immune response. Very, very importantly, it is going to be associated as it is present in the highest concentration and is the only antibody which can cross the placental barrier. Of course, we understand it is required for activation of the complement system, required for the process of opsonization, and that is why it is going to be of importance in defense. The moment we are talking about IgA antibody is going to be the first line of defense that's present in physiological secretions in the body, and it is going to be present either in the monomeric form or in the dimeric form. One of the other roles of IgA antibody is that it is going to be required for activation of the alternate pathway of the complement system. When we are talking about the other antibodies, we are aware of IgM antibody, which is having an important property. It is going to be having M for, remember, MAGA and macro. So it's going to be the heaviest antibody and the biggest antibody, having a very, very important role that it is going to be playing with respect to the primary immune response. And it is going to be associated with a special name, millionase antibody. When we are talking about IgM, it is going to be functioning as a B cell receptor. Another antibody which can function as a B cell receptor happens to be IgD. So what we observe is that at times when you are going to be having an exposure to an antigen, there can be a simultaneous formation or simultaneous production of IgM as well as IgD. Of course, IgM is produced in a higher amount, IgD is produced in a slightly lesser amount. So antigenic exposure can result in IgM and IgD production simultaneously. What is the mechanism because of which IgM and IgD are going to be produced simultaneously? This mechanism is going to be given the name of alternative RNA splicing. Alternate RNA splicing. So alternate RNA splicing is a mechanism because of which IgM and IgD are going to be produced simultaneously. Of course, this is not to be confused with another situation wherein we understand that the first exposure of an antigen is going to result in the formation of an antibody, that is IgM antibody, and subsequent exposure is going to result in the formation of antibodies like IgG, IgA or IgE, right? So acute infections or primary immune response having IgM, subsequent exposure is resulting in formation of IgG, IgA or IgE. This situation is what is going to be given the name of isotype switching. So when you have IgM and IgD produced together, that's given the association or with the mechanism alternate RNA splicing. And when we are thinking in terms of IgM initial production followed by production of IgG, IgA or IgE, that's given the name of isotype switching. Now, why isotype switching takes place? This is under the influence of certain types of cytokines, usually interleukin 4 and interleukin 5. That's what you need to keep in mind. Finally, making a mention of the last type of antibody, which is going to be having a lowest concentration, IgE antibody. It is responsible for mediating the type 1 hypersensitivity reaction or the immediate hypersensitivity reaction. Receptors for the IgE antibody are present on the surface of mast cells. They can also be present on basophils. Very, very important antibody so as to fight infection against parasitic organisms as well as in context of allergic conditions, right? Having said that, we need to be familiar with the different examples of the antigen presenting cells. We have two examples of antigen presenting cells. The first category that is going to be given the name of professional APCs and the second category that is given the name of non-professional APCs. Amongst the professional APCs, we have three important examples: dendritic cells, macrophages and B cells. And if you look at the dendritic cells, the most important example of a dendritic cell is going to be the Langerhans cell present in the skin. Remember, Langerhans cell, the same cell which is having the presence of Burbeck granules. And the electron microscopic appearance of those Berber granules were associated with the term tennis racket appearance. Of course, if I were to look at something like the endothelial cells, fibroblasts, thymic epithelial cells, and we are thinking in terms of something like the glial cells or the pancreatic beta cells, they are the examples of non-professional APCs. What exactly is going to be required for the activation of the immune system is interaction between the APCs. Why are the APCs and the T cells? Why are the APCs going to present the antigen? Is because of the presence of special molecules which are given the name of MHC. Remember, MHC is a group of genes which is present on short arm of chromosome number 6. We have got different types of MHC molecules, structure of which is what I would like you to revise quickly over here. We have got MHC1 and MHC2. MHC1 is going to be having the antigen attachment site which is present between the chains which are alpha 1 and alpha 2 chains. Whereas MHC2 is having the antigen attachment site between alpha 1 and beta 1 chain. Remember the basic fact, MHC1 is going to be responsible for causing activation of CD8 T cells and MHC2 is responsible for causing activation of CD4 T cells. So the simple rule of 8 as we understand, 8 into 1 is 8, 4 into 2 is 8, that's how we remember it. MHC1 present on the surface of all the nucleated cells as well as platelets. MHC2 is present on the surface of all antigen presenting cells. Whenever we are going to be talking about the MHC1 and MHC2, we also aware of the fact MHC is also given the name of HLA. So MHC1 is also going to be having 3 components which include HLA-A, it includes HLA-B, it includes HLA-C. Whenever we are referring to MHC2, it is going to be having the components which are going to be HLA, DP, DQ and DR. Right? So these are going to be important so far as their expression is present on the surface of antigen presenting cells, and because of the attachment of the antigenic peptide, now specific types of immune cells in the body are going to get activated. What exactly is going to be causing the activation is going to be a two-step mechanism, and this two-step mechanism is what is best understood with the help of looking at this diagrammatic representation. So let us say we are having the presence of a APC and we have to activate a cell which is going to be a T cell over here. So first signal which is going to be generated is because of the attachment of the antigenic peptide between the T cell receptor and MHC. This is responsible for generation of signal 1. This signal 1 is not sufficient for activation of the cell of the immune system. We need to have the presence of co-stimulatory signals because of which a second signal is going to get generated, and this is what is responsible for causing activation of the immune cell. First signal and second signal both are required for immune cell activation. Why? This is a defense mechanism or a safety mechanism of the body. If the immune cells are coming in contact with self antigens, there is no generation of signal 2. If there is no generation of signal 2, the immune system is not going to act against self antigens. So this is a defense against activation against self antigens, right? And this mechanism is what is going to be given the name of tolerance. This mechanism is what is going to be given the name of tolerance, right? Now, a special situation is what is to be considered by you when we are talking about the example of APCs, which is going to be B cell and the interaction between T cells. First interaction, of course, is between the antigenic peptide switch between MHC molecule and T cell receptor. Second interaction that we need to remember over here is going to be taking place between the co-stimulatory molecules, which is going to be CD40 and CD40L. Remember, CD40 is what is present on B cell, CD40L is what is present on the T cell. Why that interaction is important? This co-stimulatory signal is responsible for the secretion of cytokines or interleukins, interleukin 4 and interleukin 5. And their role is very, very important because they are required for the process of isotype switching. What was isotype switching? We repeat that. We have initial formation of IgM antibody, and during the subsequent exposure, there is formation of antibodies like IgG, IgA or IgE. So we need to have the presence of the co-stimulatory signal, because of which we have formation or secretion of interleukin 4 and 5, because of which we have the isotype switching phenomena takes place. Now imagine a condition in which there is any problem with the co-stimulatory signal. Suppose CD40 is defective or CD40 ligand is going to be defective. That means there will be no secretion of interleukin 4 and interleukin 5. So this step, isotype switching, cannot take place. Any defect therefore in CD40 or CD40 ligand is going to result in defect in isotype switching. So what will be the experience of these patients? They will not produce IgA and IgA, and they are going to be producing only and only IgM. So that condition, because of which there is a defect in the isotype switching, is going to be associated with overproduction of IgM antibody, and that was an INA question. This would be associated with hyper IgM syndrome. I hope the concept is clear. That's what you need to remember so far as activation of the immune cells are concerned. Now, having a mention of the fact what is happening in context of self-antigens, there is no generation of the co-stimulatory signal, and therefore there is going to be no activation of the immune cell. Now, when there is no activation of the immune cell, that is only required when you are having the self-antigen being presented, and this mechanism is what is going to be called as anergy. So, when there is an anergy, no activation takes place, and this is very important for the purpose of tolerance. When we are talking about tolerance, it is being defined as non-activation of the immune system so far as self-antigens are concerned. This can be of two types, central tolerance, or this can be because of peripheral tolerance. What can be the meanings of these terms? Central tolerance means non-activation of the immune system within context of the cells developing in the thymus and the bone marrow, right? Central organs means central lymphoid organs, the primary lymphoid organs, thymus and bone marrow. One mechanism can be which is given the name of receptor editing. Receptor editing is if there is a self-reactive B cell, then the body is going to change the shape of the B cell. There is alteration in the shape of the B cell. That's called as receptor editing. Second mechanism is self-reactive B and T cells are going to get deleted by the process of apoptosis. So it is applicable for both the B as well as T cells, and they die by the process of apoptosis. A third mechanism is associated with T cells, and T cell function is controlled with the help of a gene that is given the name of AIRE gene. AIRE gene. Now, if there is going to be a defect in this gene, of course, the self-reactive T cells will be there. And if there are presence of self-reactive T cells, then this is going to be associated with development of a syndrome which is given the name of APS, autoimmune polyendocrinopathy syndrome. So I repeat, receptor editing is for B cells, AIRE gene is for T cells, and when there is self-reactive T cells or B cell groups, they may be destroyed by the process of apoptosis. The moment we are thinking in terms of peripheral tolerance, the process of apoptosis is applicable here also. Destruction of self-reactive B and T cells in the peripheral circulation. We are going to be having the presence of certain special sites which are going to be given the name of immune privileged sites. Immune privileged sites are those sites in which the antigens are going to be hidden. They are going to be sequestrated. And I must remind you that these are the same tissues in which the antigens are hidden. That includes the tissues like brain, that includes eye, and that includes testicular tissue. These are the sequestrated antigen tissues, or these are going to be the immune privileged sites. We also have cells which are going to be controlling the activation of the immune system, which includes the presence of T regulatory cells. Why do they control the activation of the immune system? Because they secrete cytokines like interleukin 10 and TGF beta. Remember, interleukin 10 and TGF beta are examples of anti-inflammatory cytokines. They reduce the WBC activation at the time of inflammation. They also require the support of certain types of molecules like CD25, and they may require the role of FOXP3. So CD25 and FOXP3 is required for the normal functioning of the T regulatory cells. If for any reason there is a defect in the CD25, then this is going to be associated with a high risk or development of a condition like multiple sclerosis. And if a patient is going to be having a FOXP3 defect, it can result in development of a syndrome that is given the name of IPEX syndrome. IPEX syndrome, that is immune dysfunction, polyendocrinopathy, and X-linked syndrome. When we are talking about the presence of anergy, anergy means that the activation is not taking place. That is usually because of improper co-stimulatory signal. So there can be a problem at the level of co-stimulatory signals, and this can be because of a T cell problem. T cell energy is going to be seen because of decreased CD28 function, and B cell energy can be seen because of a decrease in the functioning of the CD40. So these are different mechanisms that we need to remember so far as the peripheral tolerance are concerned. Now imagine a situation in which tolerance fails, which means immune system is going to start attacking self-antigens. That would be a condition that is going to be associated with development or high risk of autoimmune disorders. So what can be the reason for the autoimmune disorders? Primarily because of loss of tolerance. Mechanisms can be so many, but the first mechanism could be because of a genetic factor. Number one gene which can contribute to development of autoimmune disorders can be the presence of a gene that is given the name of PTPN22. There can be other factors as well. I must make a mention of over here the activation of the B cells. So polyclonal B cell activation, a mechanism that is highlighted when there is an infection caused by Epstein-Barr virus or an infection caused by HIV. We also have a mechanism associated with molecular mimicry, similarity between the microbial antigens and the normal tissue glycoproteins, for example, rheumatic fever. Another mechanism working in rheumatic fever happens to be spreading of the cryptic or the hidden epitope. And we can have infections which are responsible for causing upregulation of co-stimulatory molecules. So all these mechanisms can be responsible for increasing the risk of development of autoimmune disorders. Once we have understood this, we need to have an idea about then the concept of organ transplantation. Whenever there is going to be a dysfunction of an organ to an extent, when it is going to be functioning minimally, it can be replaced, and that is given the name of organ transplantation. Because you are going to be putting an organ, this is going to be an external organ. So a lot of times there is going to be activation of the immune system of the recipient. Now, when we are going to be taking the organ, depending upon the source, we can be having different types of the donors and different types of the transplants. The terms are being used. One can be a patient who is going to be given or having the name autograft. Auto means self. So say for example, a skin transplant or a hair transplant, for that matter, sometimes even a bone transplant, donor and the recipient are same. If the donor happens to be identical twin of the recipient, we use the term isograft. We can have a situation where the graft has been taken from an individual from the same species. Say for example, somebody suffers from a kidney transplant. He's taking a kidney from an unrelated individual, or for that matter, related individual from the same species who is not an identical twin, right? And there can be a condition when the individuals are going to be taking the organ, which is going to be coming from a different species altogether. That's given the name of a xenograft. So autograft, isograft, allograft, xenograft. Classical example of this was going to be including something like the cardiac valves, right? Whenever there is going to be a transplantation taking place, we have two important types of issues which may be observed. One which is going to be given the name of transplant rejection. So transplant rejection takes place because you are putting an external organ in the body of the recipient. The activation of the immune system of the recipient can take place against the transplant, against the graft. So that is what is going to be given the name of transplant or graft rejection. Depending upon the timeline, this graft rejection can be divided into or has three subtypes. One can be hyperacute rejection that takes place almost immediately. And this is going to be associated with the reason within a span of minutes to hours. And one of the attributable reason over here is because of formation or presence of preformed antibodies. This is usually seen more commonly if there is a blood group mismatch between the donor and the recipient. So these preformed antibodies are going to activate the coagulation cascade, and you would be having the formation of a clot or a thrombus within the blood vessels. Say for example, within the glomerular capillaries in case of a kidney transplant. Because the transplant rejection over here is taking place within a short span of time and because of preformed antibodies, this is said to be an example of a type 2 hypersensitivity reaction. Possibility number 2 is that the transplant rejection takes place after a gap of many days to weeks. So then that is going to be given the name of a acute transplant rejection. Acute transplant rejection. The acute transplant rejection is something which is going to be seen because of either the cells, the CD4 and the CD8 T cells both may be involved, or because of antibodies. If it is because of cells, that's called as a cellular rejection. If it is because of antibodies, that is called as humoral rejection. Eventually, there is a WBC infiltration and there is going to be a failure of the graft. Now, when there is a humoral rejection, the mechanism is associated with activation of complement system. And they have a classical marker which is given the name of complements 4D, which gets deposited in the glomerular capillaries, which is considered as therefore a marker for humoral rejection. Acute rejection is going to be considered as an example of a complex, that means an example of a type 4 plus type 3 hypersensitivity reaction. We can be having a situation in which the transplanted organ is going to be facing a problem after many years or many months. Description in the textbook says on the basis of a hypothetical parameter, if it is taking place less than 6 months, we call it as acute. If it is taking place after 6 months, we call it as chronic transplant rejection. Again, cells are involved. Antibodies are involved to a minimal extent. CD4 T cells, CD8 T cells involved, and they are responsible for causing an attack or infiltration. And there is going to be a development of atrophy and fibrosis of the affected tissue. This is again going to be an example of a type 3 plus type 4 hypersensitivity reaction. We can be having a situation in which the other opposite happens. So what is happening is that this is a host, let us say. You have put a transplant. Till now what we are talking about over here was that the transplant was being attacked. Right? So this can be hyperacute, acute, or this can be chronic. Of course, logically speaking, nowadays we are having the availability of powerful immunosuppressive drugs. So the commonest type of transplant rejection that is observed clinically is most of the times it is going to survive beyond 6 months, and therefore it is going to be an example of a chronic transplant rejection. How can you minimize the chances of a transplant rejection? You have to match as many genes between the donor and the recipient. At least the scoring has to be as perfect as possible, but what has to be ensured is the most important gene which has to be matched essentially for reducing the chances of a transplant rejection is HLA-DR. So as a good doctor, that's what we talked about in the video as well. As a good doctor, you must remember HLA-DR matching has to be done, and preferably the blood group, if it is going to be similar, then that is going to be always helpful. We can be having a situation in which the problem which can take place is that the transplant or the graft happens to be very strong. It's immunocompetent. And the host happens to be immunocompromised. So now what will happen? The transplant or the graft is strong. The host is weak. So what will happen is the transplant starts attacking the host. Because the graft is now attacking the host, so it is going to be given the name of graft versus host disease. Now when we are talking about graft versus host disease, depending upon the time frame, this is going to be associated, either it is going to be observed in less than 100 days, so it is going to be given the name of acute graft versus host disease, or it is going to be observed after 100 days, so it is going to be given the name of chronic graft versus host disease. Now, when we are talking about graft versus host disease, it is relatively commonly observed in case of which type of transplants? Classical example would include bone marrow transplant, and it can also be associated with patients suffering from hepatic transplantation, right? In this situation, classically, you get initial involvement of an organ like skin, then you get involvement of the GI tract or the intestine, and then you get involvement of the liver. So you have initial involvement of the skin, you have an involvement of the intestine, and you are going to be getting the involvement of the liver. In the involvement of the skin, the patients are going to be having a development of rash. Gut involvement is in the form of development of a diarrhea, relatively abdominal pain and bloody diarrhea. And hepatic involvement is in the form of development of jaundice, right? So that is what is going to be important. And we have a clinical criteria that is given the name of a Billingham criteria that is useful for making a diagnosis of something like the graft versus host disease. So whether it is acute or whether it is chronic, that is going to be done because of the involvement of the skin, intestine and the liver. That's what we need to remember over here. Having a quick recap about the different types of hypersensitivity reactions, and the table is going to become very handy for you to remember in your exams. The moment I'm thinking in terms of a type 1 hypersensitivity reaction, first time exposure, no clinical symptoms develop, but there would be development of symptoms which is going to be seen in the subsequent exposure. Which antibody is going to be involved? IgE antibody. There is presence of IgE antibody attaching themselves on the surface of mast cells, and during the repeated exposure, the mast cells are going to get degranulated. So therefore, you would be having release of chemicals like histamine, you would be having release of chemicals like prostaglandins, leukotrienes, eosinophils can be increased, but as all of you are aware, neutrophils are not going to be involved in the early phase of type 1 hypersensitivity reaction. Lots and lots of examples of type 1 hypersensitivity reaction, but examples that we need to keep in mind are A for allergy and atopy, B for bronchial asthma, C for Cassoni's test, that is for hydrated cyst disease, and D for drugs, primarily injectable drugs including penicillin. Type 2 hypersensitivity reaction. This is antibody mediated hypersensitivity reaction. So this is going to be associated with antibodies targeting a cell-bound antigen, and they can activate the complement system or they can result in dysfunction of the target antigens, because of which the patients can be having an issue. The acronym, as most of you may be familiar, is going to be myasthenia gravis for my blood group, blood transfusion reactions, that is a mismatched blood transfusion reaction. Group for Goodpasser syndrome as well as Graves' disease. I for immune hemolytic anemia and immune thrombocytopenia. R for rheumatic fever and Rh incompatibility. H for hyperacute transplant rejection, which we just now discussed few minutes back. And P for positive, that means pernicious anemia pemphigus vulgaris. So my blood group is Rh positive, will help you remember most of the conditions that you associate with the presence of something like the type 2 hypersensitivity reaction. We have type 3 hypersensitivity reaction, which has been asked in the exam. And this one is going to be having the presence of antigens which are going to be soluble in nature. So when you have formation of antibodies, there is formation of antigen antibody complexes. They would be getting deposited in different tissues in the body. And when they get deposited in tissues in the bodies, they would activate the complement system and damage the affected areas. The examples are going to be including SHARP, serum sickness, and SLE. H stands for henoch-Schönlein purpura, which is nowadays called by the name of IgA vasculitis disorder. A for Arthur's reaction, R for reactive arthritis, and P for post-streptococcal glomerulonephritis and polyarthritis nodosa. Special property about type 4 hypersensitivity reaction, the one on which most of the questions have been asked in the exam. This does not involve any kind of an antibody. So this is going to be cell-mediated hypersensitivity reaction. In the pathogenesis, there is going to be involvement of the helper T cell type 1. There will be secretion of cytokines like interleukin 2, interleukin 12 and interferon gamma, which are responsible for causing activation of macrophages. There can be formation a lot of times of a microscopic structure that is given the name of a granuloma. And you would be having it at times associated with pathogenesis in which there is going to be activation of CD8 T cells, that means a cytotoxic T cells. Examples can include conditions like contact dermatitis, that can be including a condition like type 1 diabetes, that can be including multiple sclerosis. We can be having it in patients who are going to be suffering from rheumatoid arthritis, psoriasis, Mantoux test, inflammatory bowel disease, and different examples of granulomatous vasculitis disorders, including temporal arthritis and Takayasu arthritis. So the pathogenesis is what we just need to quickly have a recap, and we need to have, more importantly, the idea about the different types of clinical examples of conditions which are exemplified with the presence of different types of hypersensitivity reactions. Of course, I must add over here that type 2 is what is going to be associated with hyperacute transplant rejection, and type 4 is going to be playing a role in the development of acute and chronic transplant rejection. Right? So that's about the hypersensitivity reaction, friends. And then we can talk about the examples of the important immunodeficiency disorders. When we are talking about immunodeficiency disorders, they can either be primary, the ones which are mentioned over here, or they can be secondary. The commonest reason for a secondary immunodeficiency disorder, as we understand, is malnutrition. And another important example of an infectious cause of secondary malnutrition happens to be AIDS, and that is because of HIV infection. Now, having a look at the primary immunodeficiency disorders, we need to be familiar with the condition that is given the name of Bruton's disease. Remember, Bruton's disease, alphabet B is what is going to be important. So it is going to be affecting boys, X-linked recessive disease. B cells are affected because of a problem in B cell tyrosine kinase. Patients are going to be having high risk for development of bacterial infections. And there is going to be presence of the areas which are associated with B cells which are going to be underdeveloped.